Thank you very much. Welcome to this meeting of the Perth and Integration Joint Board of Wednesday, the 29th of 2023. Apologies for the slightly delayed start. There was a committee meeting in the chamber which ran on immediately preceding this. My name is Councillor Colin Stewart. I'm the chair of the IJB. I'm joined on my immediate right by Jackie Jensen, Vice Chair of the IJB, on my left by Jackie Pepper, the Chief Officer of the IJB, and by Mr Taylor from Committee Services, who's assisting with clerking the meeting, but the clerk, Mr Hendry, is online. I ask, do we have any substitutions?
Yeah, thanks, Chair. We have an apology from Susie Flower for this afternoon's meeting with, I believe, Valerie Davis substituting, and also apologies from Dave Henderson and Sandra Auld.
Thanks, and if you could just check who's online for us.
Can I just run through the ones that are online just to make sure they can actually hear this meeting, if that's okay? Angie McManus?
Yes, I can hear you, thanks.
David Shaw?
Yes, I can hear you, thanks.
Yep. Debbie Hubband?
Yes, I can hear you.
Evelyn Devine?
Yes, I can hear you.
Lisa Mulligan?
Yes, I can hear you.
And Lindsay Hunter?
Yeah, I can hear you.
And finally, Sandy Watts?
Yes, I can hear, thank you.
Thanks very much. And I note also that Mrs Summers has intimated that she'll have to leave the meeting a bit early. So thank you for attending this first part. Do we have any, moving on, do we have any declarations of interest in items on the agenda today? Dr. Peters.
I just want to make it known that the GP surgery that we'll be discussing is part of I'm the cluster quality lead for the cluster, so I do work quite closely with that practice.
Thank you. Do we have any other declarations of connection or interest? Nope, thank you very much. Next item on the agenda then is the minutes. Can we agree the minute of the meeting of Perth and Kinross IJB of the 20th of September? Thank you. Thanks. And can we agree, we'll move on to the minute of the special meeting of Perth and Kinross IJB for the 27th of October. Mr. Councillor Illingworth.
During that meeting, I made a comment about this Integration Joint Board's expenditure on 2C practices. Could I ask that comment about how this board is spending a lot of money on 2C practices that we get no benefit on is put into the minutes, please? Great, thank you.
Yes, we can do that. The Assistant Clerk to the Board indicates that that's possible. And then can we have a comment from Lindsay Hunter, please? Oh, I'll just read it out.
I've actually put it on the chat, so
okay.
I don't need to say it.
Yeah. Okay, so it was just to record that you'd sent your apologies for the previous IJB, and we'll update that as well in the minutes. And then Interim Chief Finance Officer, do you want to? Well, I'll tell you what, we'll agree the minute first. If so, with those changes, can we agree the minute of the 27th of October? Yep, thank you very much. And Interim Chief Finance Officer, you just wanted to provide us an update on the matter that we were discussing.
Thank you, Chair. I wanted to make the board aware that subsequent to the meeting on the 27th of October, where we approved the Health and Social Care Partnerships winter plan, we have very recently had confirmation that the Scottish Government will support hospital at home costs that are incurred over the winter period until March 2024. This funding is only one-off, but we weren't aware of that at the meeting at the end of October, and that funding will be built into the next financial position report that's brought to the Audit and Performance Committee on the 11th of December.
That's great. Thank you very much for the update. Next item on the agenda is the action points update. Chief Officer.
Thank you very much, Chair. In relation to the action points, in relation to 1.142, we're still trying to identify a suitable date for that, because we do have a series of development sessions planned with full agendas for those, but we'll continue to progress that. And in relation to action 144, we have a date identified for that visit to the public dental services at Broxden on the 6th of March. Thank you.
Thank you. Do we have any questions on the action update? No. Okay. Are there any other matters arising then? No. Great. We'll proceed then to the substantive items on the agenda today. First of all, we'll have an update, a strategic update from the Chief Officer, and then when we move on to the subsequent papers, can ask if members who've got access can put a Q in the chat for a question or C for a comment, particularly members online. If members in the chamber don't have access to the chat function, then just make sure you attract my attention so that I know you want to come in. Chief Officer, your strategic update, please.
Thank you very much, Chair. I'm going to talk through three key areas of update for the Integration Joint Board that are not contained within the papers in front of you today. The first relates to an update on the matter of the age-friendly communities, which I mentioned previously. Since we last met as a full IJB on the 20th of September, Perth and Kinross Council passed a motion at its meeting of its council on the 4th of October. That was put forward by Councillor Ian Massey and in support of an application to the World Health Organization for accreditation for Perth and Kinross to become an age-friendly community, and to commit to becoming an exemplar for enhancing the lives of its older residents. Joining that global network for age-friendly cities and communities would enable Perth and Kinross to access latest research, knowledge and best practice on healthy ageing and well-being, and allow us to be informed about evidence-based practices and programmes that address physical, mental and social aspects of health and ageing, and prioritising the quality of life of older people is likely to have a very positive impact on the health of our communities and our social care delivery plans for older people, and in the long term assist us with our aim to reduce health deterioration and healthcare costs, and at the same time create a more vibrant and age-friendly society. So I know Councillor Massey has been working closely with Zoe Robertson and her team to prepare an application for submission next week. And there was a very positive open event that took place last week with contributions from South Ayrshire, which is another local authority in Scotland that is a member of the global network, and will keep you informed and updated and introduce key aspects of this work in our updates to IJB in due course. So it's a very positive position for us. I'd also like to address, secondly, challenges around our continuing ability to secure capacity and flow across our health and care systems. And as you know, that has an impact on delayed discharges locally in Perth and Kinross. The IJB has received previously detailed reports on our work to sustain discharge without delay, and the work led by Evelyn Devine as Head of Health and Amanda Taylor as Senior Service Manager for Older People. Our focused work on this continues with daily and weekly monitoring, and a range of improvement actions are being implemented, and our position continues to compare well nationally and against our comparator health and social care partnership areas, who also face the challenges of rurality and higher levels of older people. And so we're performing below the national position or the Scottish position. But in the last 2 to 3 weeks, we've seen experiencing an increase in numbers of people experiencing delayed discharge, mainly from our wards and PRI and in some aspects of our community hospitals. And that's mainly due to availability of care at home support to enable people to return home safely. So what that does mean is that we are already struggling to maintain the standards that we set out, or the aspirations in the winter plan. It's probably helpful to note that Angus and Dundee are also experiencing increases, but it's more acute in Perth and Kinross. However, we continue to have a whole system approach to managing this and to optimising our current in-house care at home services to be able to continue to manage that down. Rural community funding is something that's hot off the press, and I'm pleased to give an update to the IJB. Rannoch Community Trust and Dunkeld, Burnham and District Community Development Trusts have secured funding from the Community-Led Local Development Fund, and that's from the Scottish Government. And they'll be using this funding to gain an in-depth understanding of and arrangements to develop solutions to the challenges of providing care and support to people around Kinloch, Rannoch and Dunkeld, which are, as you know, more rural areas and more challenged in terms of provision of social care. So this work will be led in a partnership approach with the 2 community development trusts, an organisation called Support Choices, and the Health and Social Care Partnership, along with Scotland Community Interest Company called SKS. And the aim is to develop a model on models of community-led care, which aligns with our strategic direction. That's the IJB strategic direction around sustainable models of social care and care at home in rural locations. And in addition, I think it was only yesterday or the day before, Zoe, the partnership received confirmation that the Scottish Government has allocated £25,000 to enable us to work alongside that. And that's for rural community-led feasibility studies to run alongside the work of the 2 community development trusts. So I think that's probably pretty good news for us in terms of breaking new ground there and looking to see what can be achieved in our most remote and rural locations and to support sustainable models of care locally. So thank you very much for that. Happy to take any questions, Chair.
Questions for the Chief Officer, Mr. Benson.
Thank you very much, Chief Officer. I very much welcome that last statement you made about remote and rural communities and how they're involving community development trusts. I think that's a great step forward, and the alliance model that you have described makes local service provision viable for so many local groups in a way which they can't currently do because of employment issues. And I think perhaps at some stage I would welcome a fuller development session, perhaps at one of our other locations out with Perth one day. It would be very good to do something in, say, places like Kirriemuir or Dunkeld or even Redalbin, for example. Would be really good just to demonstrate how it works. Thank you.
Mr. Black.
Actually, SDS, I heard you say there, that company, who are they and what's their track record?
Yeah, they've got a really significant track record in working in rural areas specifically, Martin. I was desperately trying to bring up the email with a list of all the different projects that they've been involved with, but I'm more than happy to share that. They were direct awarded the contract to work with Kinlochranach Trust based on that experience. So I'm really confident in their ability to be able to lead this work in particular.
Any more questions? No. Okay, great. Thank you, Chief Officer. So we'll now move on to, we've got a block of 3 items on to do with mental health. First of all, we're going to hear a strategic update on Tayside Mental Health Services. Then we're going to consider the annual update on our Perth and Kinross Community Mental Health and Wellbeing Strategy. And then I'm delighted that we've got Wendy Given, the Chief Executive of the NUC, and Shirley, one of the service users, along to give us a presentation. But if we can start then with the strategic update on mental health services, and Chief Officer, you're going to give an introduction to that report.
Thank you very much, and I'm hoping that our guests will have better use of the microphones than we've managed to demonstrate so far. So thank you very much, Chair. This is the strategic update on the Tayside Mental Health and Learning Disabilities Whole System Change Programme, and you'll know that the IJB approved that in June 2023. And a similar report will be provided to meetings of the Angus and Dundee IJBs and the NHS Tayside Board in December. You're asked to note the high-level progress and to agree to the streamlining of the reporting as we move into the next calendar year over 2024, because it has been a bit of a challenge to manage the reporting to different groups, as there's a keen interest in this and people are seeking that update. But to be able to do that in a way that where people are receiving the same information at roughly the same time is challenging, and this is an attempt to achieve that. The programme board met on the 26th of October and again on the 15th of November and received more detailed reports than you have before you today on each of the work streams, and this report is outlining the high level detail of that, high level of the work that's been taken forward, and it gives a bit more detail on a presentation that was received around the progress around integrating mental health and substance misuse services, which, as you know, has been more focused in Dundee. And pleasingly, this report informs you that the Cora Foundation has agreed to continue funding for project management and clinical support for that work, and have agreed to support its rollout across the other 2 health and social care partnership areas. So that's pleasing to hear. There's been recent activity and quite significant activity over the month of October, and I'd like to thank all of the IGB members and attendees who contributed to and attended some of the events in October. And these have been particularly positive in continuing to develop the culture that we want to support, the commitment to co-production and making that a reality, and developing a shared understanding across the IJBs in particular and the NHS Tayside Board. And by way of a further update to aspects of the report, in paragraph 2.7, it mentions a revised model or a new model, single model of care, and I can advise that Dr. Peter Lefevre has led on the production of a draft model, and that will be shared with the programme board in December and discussed in more detail in January. And at a meeting of the Perth and Kinross Strategic Planning Group yesterday, we are going to invite Dr. Lefevre to lead a discussion on that with the group. and there will be a further plan prepared to ensure that this draft model is discussed and considered and informed by a wide range of groups to refine it and take that forward. So very good to see that coming to fruition. At paragraph 2.8, the operational director post was not appointed to, and I'm pleased to confirm to the IGB that Barry Jenkins, who's the newly appointed Deputy Chief Executive for NHS Tayside, is going to assume the role of Executive Lead for Inpatient Mental Health and Learning Disabilities, and is beginning to pick up on that role in the absence of Claire Pearce, who's on a period of planned leave. At paragraph 3.2, I can update you that the draft recovery plan has been produced and will be considered in more detail next week by the Executive Leadership Group, and there is a plan to bring that forward to the IGBs in relation to the recovery plan around inpatient mental health budget. So that's my introduction. Thank you very much, Chair.
Thank you very much, Chief Officer. Can I invite questions from? I'll have one then. Against priority 1, which is about adult inpatient redesign, there's mention of an early draft of a single model of care to be prepared mid-November for consultation and engagement, and I just wondered where we were up to with that.
Thank you. That's the model that I was describing that Dr. Lefevre is bringing forward, and I think it will be really positive to bring that to the strategic planning group and have wider discussion. I will be suggesting that he does so across the 3 groups for the 3 IGBs, because they will all have a strategic planning group. It's a statutory requirement, as well as the range of stakeholder groups involved in the mental health and learning disabilities improvement programme. So that's where we are at this point in time. So it's coming forward, but not there yet. But I think it's important that these strategic planning groups, with the wider representation that they have there, and I'm looking over at Chris, who's going to give a more local update in our community mental health and wellbeing strategy. It'd be important that all of these groups have an opportunity to see that and to comment on it and to inform it and to take that forward, so that there is that broader ownership. So that's the direction of travel there, Chair. Thank you.
Thank you. Councillor McCall.
Thank you, Chair, and thank you, Jackie, for the report. I noticed that priority 2 is about Strathmartin physical environment, and of course we have a number of physical environments for the delivery of inpatient mental health services, and I'm just wondering how engaged you are with a wider potentially review of that, or is that factored into the service design?
Thank you very much, Councillor McCall. I'm pleased to say that there's a new Director of Facilities at NHS Tayside that you may have met, George Curley, who's joined the Executive Leadership Group. And only last week we had a conversation about having that broader or that wider review of all of the inpatient facilities. So that's beginning just now. Thank you.
And I think it's just worth mentioning that that's pulled out, Councillor McCall, as a particular priority because of the condition of the facilities at Strathmartin. Mr Benson and I earlier in the year visited Strathmartin Hospital. I'd be keen to get members of the board, let members of the board have the opportunity to visit the facilities. But I think if you visited Strathmartin in particular, you would see that it was most in need of improvement of the physical environment. Are there any more questions or comments on the mental health strategy update? No. Can I then ask if we can agree the recommendations that we note the updated position in the high level progress update, note that there will be a report of the joint development session for board members along with members of Tayside, of the the joint development session for us that was held along with members of NHS Tayside Board, Angus and Dundee joint boards in October, and that will be circulated, and that we agree the schedule of detailed progress reports for 2024. Great, thank you very much. So the next item on the agenda then is the annual update on Perth and Kinross Health and Social Care Partnership Community Mental Health and Wellbeing Strategy. And I wonder if I could ask Chris Lamont to introduce the report, please.
Thank you, Chair, and good afternoon, everybody. So this is the second annual update of our Community Mental Health and Wellbeing Strategy. Last year's report was received, I think, quite widely in a positive manner, so I'm hoping that this year will be similar, and it is near Christmas, so hopefully everybody's in good faith. Next slide, please. So the recommendation from the main paper, as you can see, is that, hold on 2 seconds, it's gone forward. There we go. So to note the local and pan-Tayside developments, similar to what Jackie's obviously just spoken about, that are being progressed in accordance with our own mental health and wellbeing strategy, and approve its continuation and direction for the third and final year. Towards the end of next year, we will obviously then start working on a revised and updated plan, hopefully for another 3-year period, and continue to keep making progress. Also, just to acknowledge the numerous and complex factors that are influencing this work, which I'll come on to throughout this presentation. Next slide, please. So the key themes, just for everybody's awareness, and I'm sure that most people will be aware of this from our mental health and wellbeing strategy, are around early intervention and prevention, access to mental health services and support, coordinated working and a person-centred support, participation and engagement, and a continuous review of our workforce requirements. I think it goes without saying as well that we can't do this in isolation, and recognition has to be given to our third sector colleagues throughout all of this process, because yet again, we're heavily reliant upon their input and what they can deliver. Next slide, please. So this slide really just takes into context the dimensions of mental health and wellbeing, which are currently in the national strategy of NHS Scotland's mental health and wellbeing. There's seven elements to this. It is within the paper if anybody can't read it, but there's 7 elements to this, and the emphasis around this and showing this is really just to reinforce the fact that throughout what we are trying to deliver is taking cognizance of the individual's whole system of health and well-being. And there's a recognition that any one of these that doesn't fall into place, or any difficulties that arise within an individual that impacts any of these 7 elements, can then obviously have some bearing and some impact upon the mental health and well-being. And although it's not an exact science, the treatment and care of people with mental illness and mental ill health, there is a significant recognition now that individuals who have elements of their environmental, physical, social, emotional, etc. imbalance, that then obviously has a significant impact upon their whole ability to function. Next slide, please. So this slide is looking at our mental health service caseload numbers across P&K specifically. As you can see, we're just under 5,000 people that actively engage within our services. This does not take into consideration third sector organisations. This is from a statutory perspective. However, we obviously aren't able to collect that data individually, but we would recognise that many of the people that are engaged with our statutory services will also be engaging with third sector, and probably significant amounts of individuals as well over and above that. As you can see, and again, I'm not going to spend too much time on this because some of the areas of the chart are very small, but as you can see, the main element, around about 2,694, are currently engaging with our community adult mental health services. This is an area that we're currently looking at redesigning as part of the NHS Tayside redesign process. but there is also recognition that there are significant amounts of people engaging with our adult mental health services that don't fit the criteria of complex care needs. Hence the reason why over the next year, and it is within the paper, that we will be looking at redesigning a primary care mental health service model. The second element around this is obviously IDAR, or the Integrated Drug and Alcohol Recovery Team. It's worth noting that this is the second highest prevalence of individuals engaging with our services. And then obviously we're looking at our learning disability health and scope services, which is an integrated service. And if you put those two elements together, that actually takes up the second highest ratio of individuals engaging with our services. The final point I will make on this slide is the fact that 4,835 people engaging with our service makes up just over 3% of our whole population across P&K, which is round about 152,500 people. Next slide, please. This slide looks at the burden of disease mental health data, and for those that are observant will notice that this is 2019 data. However, I've no reason to disbelieve that this won't have changed significantly. Mental health, or the burden of disease data, which in this case is specific to mental health, is a measurement, and I'm also aware that Dr. Emma Fletcher's in the audience, so from a public health perspective she'll be an expert on this, but this is it's a measure of years that are lost when somebody has an illness or a consequence of a disease. So given the fact that this is per 100,000 people and we have 152,000 people, that's how we've been able to coordinate and calculate this data. It'll probably come as no surprise that the highest number of 1,392 combined years is Alzheimer's and other dementia-related illnesses, particularly given our demographic population just now. And I think I heard somewhere recently that we have the highest number of over 85s of any mainland local authority area. And we are expecting this to obviously increase substantially over the next 10 years, hence the reason why we're also following forward with a dementia transformation programme, which isn't relevant to this paper, but I'm just going to mention it anyway because I'm also leading on that. The second one, as you can see, is depression, followed clearly afterwards with self-harm, and then alcohol-related illnesses. Oh, sorry, drug use is also in there. If you combine alcohol and drug use, that would actually put that at the top if you put it from a substance use perspective, which is quite alarming in itself. The one thing that I want to highlight here, however, is, without going into all of these because I'm mindful of time, is the fact that they are all interdependent. So many people can have a depressive illness who are also consuming excessive alcohol, who might want to self-harm on occasion, also have an affiliated anxiety disorder, and the other end of the coin is somebody may well be consuming high levels of alcohol or drugs and then start to develop a dementia type illness pre what we would call 65 years of age. So you can see how it all interlinks. The other recognition I also want to make here is the fact that although Alzheimer's and other dementias primarily looks at the over 65 population, there is a recognition, particularly within our learning disability community, that people with Down syndrome are a higher level of developing dementia-related illnesses. I think they have an increased percentage of 1 in 3 across the board. So we have to also take that into cognizance as well. Next, sorry. Yeah.
Don't let up. Can I just clarify the self-harm section? Does that cover suicide, or is suicide a different category?
Suicide is a different category. Yeah. Next slide, please. So progress to date, and this is for the last 12-month period, because obviously I reported on the previous 12-month period this time last year. So we are about to commence the primary care transformation of our mental health and wellbeing services, which is going to be a huge undertaking and probably will I would imagine, probably take the next 2 to 3 years to fully get it established and make it fit for purpose. This is a government-led initiative. All the local authority and health and social care partnership areas have been recommended that this is what we do. And it forms the whole system process that is also taking place around what NHS Tayside are looking as a part of redesign of inpatient and community services as well. And I'm no doubt there'll be a paper coming to IGB probably over the next 12-month period around the primary care transformation process. I think it's also worthwhile just taking recognition of the Move Ahead service, which is one of our services in Perth City. The number of referrals have increased significantly. The volume of positive feedback consistently remains high, and they have been a key core element of the implementation of the Health Hub on the Murray Royal site. I am aware that IGB members are going to visit the Murray Royal site on the 16th of January, and hopefully they'll have an opportunity to see the Health Hub when they get up there. It's basically just a mini version of what takes place on the Nine Wells concourse. We've commenced development of the Pan-Tayside suicide prevention and awareness training, and my learned colleague to my right, Wendy, is part of all of that process as well through the NUC, and I'm not going to steal any of her thunder, so that's the only thing I'm going to mention about that at this moment in time. But this is part of the NES resource pack as well, and we want to make sure that this is a unified approach across the whole of Tayside. We have seen a significant reduction in our delayed hospital discharges for mental health. And by mental health, what I mean is learning disability, adult mental health, and older people's mental health. I've looked at the figures today, and they are at 9, and that includes all of those components, which is a huge reduction compared to this time last year. And we have been in single figures for the majority of this calendar year so far. And I think that's in no small part to the fact that we've got delayed discharge coordinators and a clearer pathway between inpatient services and our community services of ensuring that complex care packages are implemented when people go back into the community. We've also had a recent co-production with the Gannetry Trust and third sector organisations, which 1 or 2 people in this room were present at. And this is around how we can ensure that third sector organisations and ourselves can work in a much more collaborative way, but also look at how resources are currently being utilised and what is the need of our local populations and how we can start to redirect that need over the next few years. Next slide, please. Our ECT and Therapeutics service, which comes under the partnerships umbrella and is based on the Murray Royal site, have recently just been awarded accreditation with excellence, and this is a national award around what they deliver. So again, I think this is something that we needed to applaud. We have commenced also locally within the Health and Social Care Partnership our own Mental Health Clinical Care Governance Forum, which feeds into our wider clinical and professional care governance forum for the partnership. We've also started to establish, with the support of Dr. Hamish Dougal and Mr. Chris Jolly, some key performance indicators which measure across the board our mental health services. And we've managed to get some buy-in from Angus HSCP and Dundee HSCP of adopting these as well. And in turn, this potentially may also be escalated up onto a national level as well to see whether or not they could be adopted there. We've had system-wide collegiate working and support, and I've made reference to this at the very beginning around our third sector partners. And again, Wendy to my right is going to do a presentation on regards to the NUC, and the NUC have been one of our key partners around what we've delivered over the past 12 months. And workforce development. So we have seen a significant improvement over the last 12 months within our mental health nursing element across the partnership. This time last year, we had a vacancy factor of 13.5% within our nursing element, and at this moment in time, it's down to 9%. Now, I am mindful that this is work in progress. I'm mindful that nationally, we're being told that the pressures upon recruitment are going to increase because of an ageing population, etc. But at this moment in time, we do appear to be attracting more and more newly qualified staff into the partnership. Next slide, please. So the key challenges around this, and you will be pleased to hear I'm coming to an end, recruitment and retention of staff. Now, some people may well have noticed on the previous slide that was a positive. Unfortunately, at the other end of the scale, we also continue to see issues around trying to recruit medical staff and our allied health professional colleagues. But again, unfortunately, this seems to be a national issue, and we have escalated this to the Minister for Health. Winter pressures and increased demand. It's the age-old nugget of we're coming into the winter season. People tend to become more poorly, beds become more blocked, and we start to see increased demand across all of our services. The one caveat I will say here, and I did mention this last year, is that over the last few years, we have actually seen that increased demand seems to be continuous throughout the 12-month period, more so than what we were used to before COVID. Tackling our suicide rates, I have made reference to this within the wider report, but last year, unfortunately, we did see a spike in our suicide rates across Perth and Kinross. I think we were actually the highest out of all local authority areas. We don't know why. We have done a dig down into it. This is per head of population, I hasten to add. So although our numbers were at 35, obviously, when you look at Glasgow, Aberdeen, Dundee, higher population areas, their numbers are slightly higher. But per head of population, our numbers did spike last year. I've spoken to our local suicide and awareness coordinators because we have 2 of them within our local authority area. And they've both advised me that so far for this calendar year, given the fact that we only have 1 month left of it, our numbers seem to have gone back to 2021 figures. So we're trying to dig down deep and get a full understanding of what that is. Also, just to highlight, all of our suicide rates include HMP Perth and Castle Huntly because the individuals are Perth and Kinross residents. And the final challenge, obviously, is around the future financial challenges, which I don't need to go into great depth here because everybody's mindful of what's happening across the world. Next slide, please. So in conclusion, I'm bringing this report really just to highlight the progress that we've made throughout the second year of this strategic delivery plan. And again, I've already highlighted this, it's in no small part to the working that we currently enjoy between ourselves and the third sector colleagues. And I'm hoping that over the next 12 months, we will see the development of our primary care mental health transformation programme, whilst managing any ongoing issues that's already been highlighted. Thank you.
Thank you very much, Mr. Lamont. Do we have any questions? First of all, Vice Chair.
Chris, really good that you're having success with nurses and really pleased that you've saw a 27% decline in your wait times. But on the same page, on page 37, there's you comment on the ADHD waits by a consultant psychiatrist. And I know through visiting CAMHS colleagues that the waits for CAMHS is very high. Are we seeing young people moving into adulthood without having had an assessment and sitting on a waiting list?
Sorry. So yeah, that's an excellent question. So I suppose ADHD is a synopsis of some of the issues that we are seeing now. So as you know, Scottish Government a couple of years ago made a recommendation that there had to be a much more seamless transition of young people into adult services. Our colleagues in CAMHS are obviously experiencing very similar situations of what we are around staffing and capacity, etc. And a lot of the young people that have been sitting on their waiting times now are moving into adult services without actually receiving an ADHD assessment. Historically, ADHD assessments usually had to take place over 2 to 3 different consultations. It usually had to be through a consultant or at least a senior medical officer. We haven't had that ability to deliver that. We have been trying to utilise advanced nurse practitioners to undertake ADHD assessments, and we made significant progress in Perth City at bringing down the waiting list. However, then the advanced nurse practitioner went and got a different job and left. And of course, there's not a lot of advanced nurse practitioners out there either. So we've currently actually recruited 3 trainee advanced nurse practitioners. We currently, I think, have a waiting list in the region of round about 350, 400 people sitting waiting on an ADHD assessment, which in the whole scheme of things is actually relatively low compared to some other areas. However, we recognise it's still too high. So we are actually looking at ways that we can try and get on top of that waiting time.
Thanks very much, Chris. We need to try and help CAMHS get on top of theirs as well.
Mr. Sam.
It's just to go back to the point you made about the suicide. You were doing a deep dive. Will we hear more about that. It's just I'm interested in that, but also the percentage you mentioned, particularly the prisons. It would be really interesting to know which percentage of that is from the prisons, because I think that's an important thing to pull out.
Yeah, I can pull that out. I mean, like I say, we're currently doing a deep dive. What we have seen was that although males, particularly between the age bracket of 40 and 50 years old, was still our highest area of suicides, there was an increase in females, and there was also an increase in females who took their life through violent means, for want of a better word. Again, we don't know if that's a national trend. We're trying to get information. It's difficult to pull that out from a national perspective, but we're working on it. And once we've got a report, I'm happy to bring that here.
Mr. Black.
Thanks for the report. I really appreciate this report, and it's revolutionary for me in the fact that you're identifying the deaths with substance misuse. And that's first, when you see the actual impact of harm, alcohol use, drug use, anxiety, and how much year or how many years and how far down the scale it's treated by professional. And I find it absolutely alarming. I've harped on about this for years and years. And professionals will tell you if you've got depression or some other mental illnesses, you've just got the illnesses. But when it comes to addiction, they'll say it's a lifestyle choice. Well, it's absolutely, and it's not a lifestyle choice. And I wish professionals would actually start to recognise that in future planning. And because the amount of money that must have been spent prior to the deaths of these people on the health service and on other agencies is phenomenal. But to have that highlighted here, I think that's a credit in this report. Thanks.
Thank you, Martin. I'll make sure that gets fed back, and I promise I won't call you a counsellor like I did the last time I was here. I think that probably just shows why the need for us to ensure that we're implementing the MAT standards, which I know that Mr. Ogilvie has previously reported on coming back here.
Thank you. I think you had a question, but I don't know if you wanted to come in as a response to this. Dr. Emma Fletcher, Director of Public Health at NHS Tayside. I know we're coming on to a presentation, but delighted to welcome you to the meeting at this point. Dr. Fletcher.
Thank you, and I hope Chris doesn't mind me adding to a couple of the previous responses, just to flag with regards to suicides and the huge concern that poses for all of us. And there is a Tayside Suicide Multi-Agency Review Group with an annual report published that informs the work of all the 3 health and social care partnerships, and that's publicly available. In addition to the work that Chris describes, that we monitor all sudden fatalities due to substance-related harm or suicide, and work very closely to provide an acute wraparound response where required, because we're particularly alert to any emerging clusters or challenges that those can pose in addition. And I'll pull out a few more kind of Scotland-wide context with that in my report later on in the agenda. Just also to pick up on your point, Martin, what you're describing absolutely is the stigma that people with substance use face, and it's by being able to have this as focus of discussions in whichever forum we are in is absolutely critical to break down that perception of it being anyone's individual fault, because that's absolutely not the case. It's the environment, it's the context that we're living and working in. I had the pleasure of being able to give a lecture to our new first-year medical students last week on exactly what you're describing, and being able to help understand the wider context that we're living in, and how that drives patterns of behaviour and how people respond to adversity, because it's incredibly challenging. So I think just to echo Chris's thanks and to you for raising that and to reassure that it is a key focus on the work that we take forward throughout the HSCP and NHS Tasteline.
Dr. Peterson.
Apologies, I'm just going to go back to a different point. Obviously, my brain's working quite slowly today. Can I just confirm, we talked about the ADHD there and there was 350 on the waiting list. Are these just the patients that have been transferred through from CAMS to ADHD list? Because we're often seeing that there has been an increase in patients coming to us for asking for ADHD assessments, and we have no way of referring them to get that assessment at the moment. And when we do, we're getting leaflets back to share. So I would question where that ADHD waiting list and assessment is coming from, because at the moment it feels as though we're being told that there isn't a service or in fact a waiting list for patients that we are trying to refer in. I would, however, like to add to that those that have been on CAMS who have transitioned through have had a great response. They've been we've seen some really good results, but I'd just like clarity around that waiting list.
No problem, Sally. So the 350/400 people is the entire waiting list currently sitting across the 3 CMHTs, not just the ones that have come through from CAMS. What we have had to do, however, is following national guidance, we've had to put a pause on anybody being diagnosed with ADHD, as I'm sure that you're aware, because there is an international shortage at this moment in time of ADHD medication. Yeah.
Sorry, just to come in there, that's quite a recent thing, and I don't think we can use that as an excuse for why we've had to close waiting lists. So apologies, but that's quite recent over the last few months, and obviously we've been having issues for longer than that.
No, not at all. I accept that, and that wasn't an excuse. It was more just pointing out, obviously, this is something else that's currently hit us left field. The main reason that our waiting lists are high is basically because we can't bring in consultant psychiatrists to help undertake the assessments, and that is something that we continually keep struggling with in partnership with our NHS Tasteline colleagues, because they're the ones that have obviously recruiting the consultants.
Thank you. And Councillor McCall.
Thank you, Chair. I have a few questions, or maybe they're comments. I'm not quite sure which, but we'll soon find out. The first question really is just a point of clarification, really. You mentioned that suicide rates include the prison population. Is that the same for your general mental health statistics? Does that include the prison population as well?
But it's like Morse code this. No, so suicide statistics include the prison population because they are residents within P&K for that monitoring. However, our general adult mental health statistics only include what our statutory services within the partnership deal with from a community perspective. The prison reports on their own because they have their own built-in mental health, substance use and primary care services within the prison at that time.
There. No, I'm just curious because I think you're right, there's different ways of reporting, obviously you're right, but I think if you're looking at the whole round, very often there's a lot of remand prisoners who are actually, residents of Perth and Kinross who haven't reached a conclusion to their progress through the criminal justice system. And certainly in the Community Justice Partnership, we do get often reports around issues regarding residents at the prisons, particularly at Perth Prison as opposed to Castle Huntly, which of course people have been there for a while, where very often the underlying cause is a mental health issue. And so I'm just wondering how we can capture that, even if it's on the side somewhere, because it does contribute to people entering the criminal justice system, mental health issues. And so I'm just wondering if they drop off the radar or something. It's a bit of a comment I'm not sure if you got an answer to it, but I do think somehow we need to join up with these other partnerships that get reports on these things, so we can have a more complete picture perhaps going forward. And then, so that's that sort of point. The second question really is around children. Jackie mentioned CAMS, and I think Sally also mentioned CAMS as well. But we know from our education colleagues here in the council that there is an increase in demand for additional support needs in schools, and not everyone will have a diagnosed condition as such. Some of it is certainly an increase since COVID and lockdowns, and from all age groups, from early years, etc., etc. Now, I do understand that children's health sits outside of this health and social care partnership, but if we talk about prevention and detection, we need to think about how we identify the instances in children's health, and particularly those with additional support needs. Those of you who know me from other committees will know that I have an underlying, somewhat anecdotal, based on casework, concern that children who do receive additional support needs in school, but if they don't have a diagnosed condition or a recognised condition, their transition to adult services doesn't really happen. And so sometimes they fall off a cliff and they may end up then coming to the NUC or other organisations. So I think somehow we've got to think about how we join up those things as well, because children who get support at school and suddenly they leave school and don't necessarily get the support, they seem to survive for a little while, and then they struggle to access social care services, etc., etc. So again, that's purely anecdotal, but I think if we're going to be looking at the whole picture, we have to think about children's mental health somehow. And I understand, I've been told, Emma, that's under the auspices of the Public Health Committee, Children's Health. I've just had an email to tell me about that. No, that's for a different conversation. I'm trying to get to the bottom of where the governance of all of that lies. But I think for us in Perth and Kinross, particularly because there is an increasing need of additional support needs for young people, we need to think about how we can possibly do that. And my other final question, let me Chair on a roll here. You mentioned there's a 400k funding for Community Mental Health and Wellbeing Fund. Perth and Kinross Council, who obviously is a partner in this as well, have introduced last year anti-poverty task force and specific funding to alleviate poverty. And of course, poverty is very much can be a driver of some mental health issues. So I'm just wondering how we link up. This is a question. How do we link up with them and try and make sure that any activities, initiatives, or whatever that we're doing are aligned? Thank you. Thank you, Chair, for your
well, as the anti-poverty task force are meeting upstairs, I think at the moment, there's probably an opportunity to go up and buttonhole them, but Mr. Lamont.
So I can answer the last one very easily. I've actually been approached by the anti-poverty task force. So I'm going to start meeting up with them and sitting on it to see how we can tie all of this in. So that can be the direct link. I actually think the Chief Officer wants to come in around the children and young people's wellbeing.
Okay, thank you very much, Chair, for allowing me to come in. In relation to your question around children's mental health, the governance around that should sit with the Children's Services Plan, and locally that's the Children, Young People and Families Partnership. So I know that the community wellbeing funding that's come through Scottish Government following on from the mental health task force it comes through the council, but it must be a partnership approach to that, and I think that's reporting to the Children, Young People and Families Partnership. But I think that leads directly into your point around how are we as an integration joint board ensuring that we've got the connections across these other partnerships, for example the community justice and community safety partnership, etc. So sorry.
Thank you. And Dr. Dougal, you had a comment.
It wasn't related to children's service, but just those who know me who will understand I like numbers, and I wouldn't like people to go away with the impression that the prevalence of mental health issues in P&K is 3%. I think that is very clearly those who are involved with our statutory services. I think it's much higher than that. And the QOF data we have, most recent data, which is unfortunately no longer collected back in 2016, would suggest it's at least double that if you include primary care contacts. And I would suspect if you add in those who don't actually come and present to services, you'd be nearer 10%, which is 1 in 10. So it really is a very important issue.
Thank you, Vice Chair.
thinking about Sheila's answer, and I suppose I wonder if perhaps a bit of input on transition, particularly in relation to learning disability and children who have been in CAM service, might be useful for us at some point in the future, so that we can get a bit of an understanding of, as a board, of what are the challenges of transition and how are we managing them.
Yep, I'm certain that that can be arranged. And Ms. Benson.
Thank you very much indeed. Very helpful report. Given what Hamish just said about the real figures, actually are substantially higher around mental health issues, that suggests to me that this isn't just about a health and social care issue. It has major employment and economic implications, both within Perth and Kinross and beyond that. And bearing that in mind, what are your manoeuvres towards working with employment services and employers as part of this broader issue? Because they are another key stakeholder group who are greatly impacted by this across all of the services. And I wondered if you had any comment on that.
Thanks, Mr. Benson. So in my presentation, I made reference to the design and transformation of our primary care mental health services. And part of what we aim to do around all of this is to do a mapping exercise, first of all, of what we already have in place, as in what services are in situ from a statutory perspective, but also what's currently being delivered out there through third sector organisations, what we can commission additionally and re-look at from what is being done as duplication, but also start to tap into organisations around employability, welfare rights, the job centre, etc. So the whole premise of what the primary care mental health service is around ensuring that any individual with any mental health issue, doesn't have to necessarily be a mental illness, when they get referred into a system, and hopefully at some point we can make it a self-referral system, but when they get referred into the system, they will get picked up at any given point by any organisation. Because what we recognise just now is that individuals are being referred into the system primarily by GPs. They're bouncing around for quite some time. Different organisations are deciding who's the most relevant. Sometimes they're not relevant at all. It then goes back to the GP, and the GPs are left holding that person, trying to sort out what that person's problems are. So in answer to your question, and I know that that's a roundabout answer to what you were saying about employability, when that person comes in under this new model, if that person comes in and just for an argument's sake, they have depression or anxiety and it's related to relationship difficulties, employability, lack of finances, losing their house, etc., we should be in a position to access the most relevant organisation or service that can then start to deal with that person's mental ill health, but also their social issues. And that way then we're hoping to stop the trickle going upstream where people move further and further into a crisis situation.
Okay. Have we exhausted our questions and comments at this point? Great. Okay. Oh, yep, Councillor McCall, and then, oh, well, I'll tell you what, I know that you have to leave first, so Mrs. Summers, do you want to come in just now?
If we had looked at the background to suicide, you know, what maybe brought that person to doing it. And I wonder how much impact the social media has on younger people's suicides, like, you know, because there's terrible pressure on them. I just wonder if we'd ever had a look at the background to the suicide.
Okay, Mr. Lamont or Dr. Fletcher?
I was probably going to say the same as Emma, but anyway, Emma's already made reference to this Tayside Suicide Prevention Group and the Strategy Group, which has actually been given national recognition around how they look at an individual's history and what has preceded that person moving into completing suicide. So in answer to your question, Maureen, that is taken into consideration. What we need to do is, however, make sure that frontline services are trying to recognise the earlier trigger factors to stop the person moving into taking their life in the first place.
And I'd just add, with your specific point with regards to social media, it is very difficult to be able to pull that out in every history. So I don't think we have a good capture as to its impact. And I think it does, whilst there are benefits to social media for a number of different reasons, it also brings a huge amount of challenge. And I think a huge amount of challenge, particularly for our younger people growing up in a world of social media. And there will be the direct impacts and also the indirect impacts in terms of how people are benchmarking themselves against others and all the challenges that we recognise with social media, but it's absolutely undercaptured because of the limitations as to how we can collect the information. Absolutely.
And Councillor McCall.
Thank you. It's really just to reassure partners about, in response to Bob's question about additional support, not just the anti-poverty task force, but there is a wider piece of work goes on within the council. And, you know, for example, tenants coming from a homeless situation are given substantial report to help maintain and maintain their tenancies. The welfare rights team also work very well with Health and Social Care Partnership and with other agencies to try and put in wraparound supports that, you know, to alleviate some of the issues that might be causing depression or various other things. So it's just to reassure colleagues who perhaps aren't aware of all of that and the cold face that these things go on in the background all the time. Thank you.
Thanks very much. Okay, so if we move to the recommendations of the report, we're asked to note the local and cross-Tayside developments that are being progressed in accordance with our community mental health and wellbeing strategy and approve its continuation and direction for year 3, while acknowledging the numerous and complex factors that influence this work. Can we agree that? Great, thank you very much. And now we are going to have a slightly different item on the agenda. It's important to hear the formal reports as we've just done, but I think it's also important to hear how things are being delivered on the ground and how they're being delivered really well. Mr. Benson and I, Chief Officer, took the opportunity to accept an invitation along to visit the Nuke earlier in the year when you had your assessment report launched. So I'd like to invite Wendy Given, who's the Chief Executive of the Nuke, and Shirley to give us a presentation.
Thank you, Chair, and thank you for your invitation to come along today. As you pointed out, sorry, who's managing the slides? Next slide, please. Oh, yeah. So that's just for those who's in the room, that's just who we are. Sorry, I put Shirley a bit on the spot because I captured that image from a video that she had. And she was less than flattered, and mine's is actually a selfie because I don't actually have a lot of pictures of myself either. So that's the mug shots, just to let people know who we are. Next slide, please. As Chair mentioned earlier on this year, we were able to launch our independent evaluation into our Nuke services, and actually some of those people present here today actually managed to come along. I have actually brought some copies of the report here for people if they want to help themselves to them, and they can also be emailed out to members as well. So thank you very much for those of you that came along on the day, and as my picture says, we actually had our leader of Perth and Kinross Council that came and spoke to the presentation on the findings of our evaluation. Next slide, please.
So today my presentation isn't too much about the evaluation, but it's really about what's been happening since the evaluation. And I hear more and more this term of intervention, early intervention and prevention. And so I felt it was really important to share with you today and to make the connection and the link that actually, although in our title we are called a crisis centre, we are actually also providing early intervention and prevention within our centre. Within the centre, the model that we work towards is providing short-term and immediate support to individuals that have that emotional and psychological crisis. And some of the impacting factors of that were some of the things that Chris was alluding to in his presentation. And so a lot of it is life circumstances and a whole range of things. And almost every day, different people come through the door, and I think we never anticipated that, you know, seeing people with this issue. And most recently that was the stillbirth of a baby. And again, that, you know, it wasn't something that we foreseen as being a demographic of people that we would be supporting at the NUC. Next slide, please. So again, just trying to make the point that while we are that crisis centre, we know that we're reducing the burden on services. We know from colleagues across the statutory services that are saying to us, we have noticed a difference since your centre has become an operation. And I see a few nodding heads around the room. Next slide, please. So part of what we do at the NUC is the crisis stabilisation aspects, and I think our key and one of our key and unique factors is that we're able to provide immediate support to people. We don't operate a waiting list, and we provide a real safe and secure environment for people to come and speak about whatever is actually going on for them. And we put a lot of thought into the environment, albeit we were really fortunate to have Gleneagles Hotel help us with furnishing of the place. So it's actually really quite a nice space. Next slide, please. When I hear people talking about people that are impacted by suicide or the suicidality within Perth and Kinross, a big part of what we do is providing safety planning for people. Not everybody that comes to us in high levels of distress have suicidal ideation, but a good majority of people do. And so a big part of what we do is to work with safety plans for individuals. So we look at how do we get them to cope with the distress, how to identify contributing factors, and how do we avoid those triggers. And we really try and provide a right wraparound support to people in that immediate crisis. Next slide, please. And beyond that, so we don't just deal with the presenting crisis and then that's it, you know, the person goes away. We provide short-term interventions. We work to stabilise people's emotional state, and we do that with a variety of different techniques. We've had 2 quite significant staff development days this year where we've been upskilling our workforce and our volunteers around decider skills, which is a method of CBT type interventions for people, and more recently we've been looking at the model of prescribing lifestyle medication, which again covers some of Chris's earlier presentation about looking at the whole person and actually trying to help people to identify the impacts of different parts of their life on their mental health as well. Next slide, please. So some of the key skills that we actually find that we're teaching people is around emotional awareness. Yeah, it never ceases to amaze you. You think that, you know, as grown adults, we all know and recognise our own emotions. Well, actually, that isn't the case, and we quite often see people being confused as to what actual emotion it is that they're sitting with. So being able to help people through awareness of what actually a range of emotions are and how to manage that, and to recognise, you know, the difference between sadness and anger and stuff. So that's part of the work that we do with individuals. Next slide, please.
So we do teach quite a wide range of coping strategies. We try and connect people to the coping strategies, so it isn't just a case of this is here. We actually work with people. So when I say work with people, we'll sit alongside them to do the breathing techniques or to provide sensory equipment for people. So that a whole range can be offered to try and help connect people to that coping strategy. Next slide, please. And a big part of what we do is we try and fulfil people's sense of purpose, because obviously we need to create opportunities for people to learn and grow, and just really to help with well-being. And some of that was also alluded to earlier on, as can be around employment and education, but also just being able to contribute something to their back into their community. And for some people, the opportunities exist back within the NUC and volunteering with us. And Shirley is along today as a service user ambassador, and part of her role within the NUC is going out and about and promoting. So Shirley was out on Sunday at a mental health and wellbeing event, and she was promoting the work that we do at the NUC. Next slide, please. Yeah, and problem solving, we really try and work with people to change their mindset to addressing problems from a different viewpoint. So it's not about focusing on what the problem is, but it's really what the solution is. And some of that is through a range of interactions with other organisations. So if it's financial difficulties, there is citizens advice. We're really fortunate that we have Citizens Advice Bureau come and operate within the NUC one afternoon a week, which was part of a joint application to the National Lottery to have that service that within the NUC. And so yeah, we try and offer as much as possible, almost that one-stop shop approach, so that things come from out with the centre. Next slide, please. So this is, I guess, the bit that people will be most interested in, and sorry that some of the colours are a bit close, but these figures are the 6 months figures from the beginning of April this year until actually the end of October. So we have had 367 referrals within that time space, and of that, our biggest source of referral is still self. We do an awful lot of work in the community around promoting awareness that we're here, including our nice new branded clothing, which, you know, members of the public do say, you know, what is that? And it gives us the opportunity to have that discussion with people in a much more informal way. And our next biggest source of single referral is through GP practices. We've really seen a huge intake in referrals through GP practices, and one day last week we actually had 7 in one day. And we're seeing that across a wide range of practices across the partnership, including from rural locations. And the other figure, which is quite a high figure, is really made up from other third sector organisations. But again, police and social work early intervention team kind of sit at around about the same figure as well. And then the smaller ones is from our local college and Scottish Ambulance Service. Next slide, please. What have we done in that 6 months? So we've delivered 2,615 wellbeing, one-to-one wellbeing sessions since April. Over and above that, we have provided the 320 trauma counselling sessions and 380 hypnotherapy sessions. I just would like to point out at this point that our trauma counselling and our hypnotherapists are volunteers. That is not part of the budget. Our wellbeing sessions, the finances for the NUC employ wellbeing mentors. So we're really fortunate our community have really embraced us. Next slide, please. I felt it was important as well to kind of show you the uptake, because I know that I hear quite often about failed appointments, and I see myself in practices, you know, how much time's wasted in the NHS with people not attending appointments. And so out of a possible 4,680 appointments that we offered, 70.7% of people actually attended. It's massive. It's massive. The DNA that did not attend is 11.7. And the other interesting part is clients phone us up. 15% of people are phoning us up and saying, you know, I can't make it, and so the appointments are being rescheduled. So we've really got that dialogue going with people that are using the service. And then a small percentage there that we've had to cancel. What is going on in Perth City with power cuts? We've experienced quite a number of power cuts over the last few months. And coming into the winter months, it obviously means that it's not an ideal situation, but also that will account for staff sickness as well. Next slide, please. So what are we being told by people that are using our service? What feedback are we getting? So people are saying that they feel able to cope much better, and that they're actually recognising that they're changing their approach to actually dealing with things that cause them everyday stress. Next slide, please. Sorry, if I'd known it wasn't me that was operating it, I wouldn't have had it coming up. Sneaky. Positive emotions were, gosh, it's so great to hear somebody to say that they feel contentment and joy. So many people that we see coming through our doors don't have you know, much hope sometimes, and so to be able to make people say that they're actually feeling enjoyment out of life again is obviously a massive thing. But also in terms of suicide prevention, it's a real a protective factor to have our community saying that they feel much more happy and content within themselves. Thank you. They have increased motivation, so there's better engagement in daily life. So we're hearing people saying they're getting back to employment, or they're getting back to doing some of the activities and events that they enjoy doing, hobbies and such like. And increased self-confidence. People are much more feeling happier within themselves, a much more positive self-image, and putting themselves out there in the community, like Shirley sitting alongside me today. And the big one is that they're reporting a reduction in symptoms. So they're saying that they feel less anxious, or they're able to recognise the difference between everyday anxieties like Shirley and I had for coming along here today, and actual, you know, stuff that would exacerbate and lead to a much more crisis situation. Less mood swings, and again that's because people are having an increased awareness of emotional regulation and differences in their mood, and actually a reduction in depressive symptoms. And so it was interesting to see the percentage on your chart, Chris, around the impact of depression. And we, you know, it is massive, and we are actually seeing now that GPs are prescribing, sorry, they're actually referring people instead of prescribing antidepressants, and we are hearing that from patients that are coming to the NUC, that there's a whole different approach to that. And I think it's also important to say that quite a lot of people that come to the NUC may also be put on a wait list for some of the clinical services that we've heard about today. And we know that by the time they are coming to a position to be seen by clinicians, we have actually already intervened, and sometimes there isn't the need for the services to be put from the community mental health team. So yeah, we're just been able to offer a range of different options to people in Perth and Kinross. So next slide, please. Sorry, Shirley. So Shirley's now going to just, you know, I can sit here and speak about this till the cows come home, because I absolutely love the opportunity to be doing what I'm doing. But Shirley's just going to give you a wee bit of an insight into her experience of attending the NUC. So
Thank you, Wendy. I must note that's my twin sister. I've been overwhelmed by the mention of the word suicide around the table and how interested you all are, and I'm very grateful for that, because what put me in this chair here today, the journey that I've been, started with the end of my life last October, when I reached the point where I couldn't go on any further, and I took determined effort to end my life by suicide. And my plan was perfectly successful, worked out really well, except my heart wouldn't stop beating. And 2.5 days later, when I was eventually found, I was still alive enough to be worked on. And I'm thankfully here today to tell the story. So I spent a couple of months in the Murray Royal Hospital on the Morden ward, which incidentally is a fantastic place to be, and the Murray Royal staff are amazing. Several of the staff mentioned this place called the Nuke, and I'm like, the what? I'd never heard of the Nuke before, and I must say, if I had have heard of the Nuke before, there would never have been a suicide attempt. However, on discharge from the Murray Royal, the intensive home treatment team thought, with my suggestion, that it would be a good idea if I went to the Nuke and I actually met the people that were there, so that if I ended up in that crisis state again, I wouldn't feel so shy about turning up and knocking at the door. When they took me to the Nuke, the wellness mentors opened the door, welcomed me in, sat me down, gave me a cup of coffee, and I've never left. I have been very fortunate from the very beginning. I was allocated a wellness mentor, and our focus was on me in a non-clinical way that made me feel so comfortable, and I felt so welcome. And what we did was focus on ways to prevent me from being in that situation again, what we could do to improve my self-esteem, to improve my coping skills, and to look at changes that could be made within my life, because if nothing changed, then I would still end up back down the same rabbit hole. And so that was the focus with my wellbeing mentor. I was then put on to a workshop, a wellness workshop, where I spent 6 weeks learning. It was weekends, a Sunday for 6 weeks, where we further developed coping skills. We looked at ways to manage when hallucinations started, when voices started. We looked at different things that we could do with the other people there to calm ourselves, and not just as you would get recommended from the mental health services, go have a cup of tea and have a bath. I'm really sorry, but that doesn't work. What did work was the help that I got from the Nuke through the wellness course. Then it didn't stop there. The next opportunity for me was the hypnotherapy, and I went on to a 10-week hypnotherapy programme. And oh my goodness, I was as timid as a mouse, and I was so shy and withdrawn. And what the hypnotherapy did was take me from that spot and put me in the seat, be confident enough to address the integrated joint board. Well, thank you very much. Hypnotherapy is nothing like what it sounds. There's no stage hypnosis, there's no swinging clocks, there's no ticking clocks. It is very much a proper, legitimate therapy. And you are able to focus on whatever your particular need is at the time. And my need was confidence. I was in such a mess. I'd ruined the relationships I had with my family through my effort to end my life, and I had nobody. I had nothing left at all. So I had to start at the beginning and build up some confidence. Within my third session, my confidence had skyrocketed. I didn't know where this had all come from, and throughout the rest of the sessions, my life turned around. And that's what's happened through my journey at the Nuke. My life has turned around from something that was barely recognisable in January. From walking through that door, the wreck that I was, I now feel like I can cope with life. I can cope when life doesn't work properly. I can cope now when life gets really scary. Perhaps should have mentioned that my background is I have bipolar disorder, but I'm also a military veteran and I have PTSD. And those two illnesses alone cause me to have a significantly higher suicide risk, and also cause me to have a very unstable mental illness. And to know that the Nuke is there, that I lived a 10-minute walk away from the Nuke. If I'd known that, but anyway, I do now, and that I can turn up at the door and we're welcomed in by a team of wellness mentors and given the help that I need at the time, gives me the confidence to carry on in society. Now, Wendy mentioned a little bit about me doing volunteer work. It doesn't sit well with me to get something for nothing. So it's been my great pleasure to give my creative skills to the Nuke and to help them with their social media, to do videos for different events, and recently just started speaking up for the Nuke as an ambassador. It means a lot to me to be able to do that. And one of the things that being with the Nuke has helped me to do, and that's to step forward and achieve an ambition, and that's to volunteer for the Samaritans. And I started doing that a couple of months back, not as a listening member, but as a support member, working in the background, doing activities such as tomorrow, I'll be selling Christmas cards in Friday. A couple of weeks ago, I was in Morrison's with a collecting can. That's the type of things that I'm doing. And I'm absolutely delighted and privileged that I can be giving my time to mental health charities, because I'm actually not well enough to give my time to work, to employment. But one of the things that I wanted to point out, that thanks to Wendy and Derek for the charity that they've put together, I know from other service users that we and many other people may well not have been here this year to tell our stories had it not been for the services that they are making available to us. And I say thank you on behalf of a lot of people. Thank you, Wendy.
Thanks very much, Wendy, for your
our call to action in the community, and that is about trying to increase awareness in suicide prevention and eradicating stigma. And Chris alluded to the fact that we provide training and such like. So, you know, we're really trying to embrace the community and to try and promote that. Thanks, Shirley.
Thanks very much, Wendy. Thanks for the presentation, and I think thanks for the work that you do on behalf of the community. And thanks very much, Shirley, for a beautiful and clearly told story that will have affected people. And thank you for your service as well. Wendy and Shirley have kindly said that they would take questions. Sally, Dr. Peterson, you were first.
Mine isn't a question, mine is a comment. So I'm a huge fan of the Nuke from experience as a GP. My office is full of the magnets and the stickers you gave up. If there's any branded T-shirts going, I'm more than happy to take them. And I think I see it on a day-to-day the great service you can offer people that I can't do in an urgent appointment when people present. One of the other things which I think is a real positive that I've noticed is we expect a lot from our reception teams. They are expected to be signposting their first contact with patients who ring up in crisis, and that can be really upsetting and really difficult for them, and it particularly is one of those conditions that people really worry about talking to patients about. However, one of the real positives I've noticed, which I wanted you to be aware of, is that our reception teams are really positive about referring patients to you, about giving the number. There is a confidence there that means that they do feel that patients will get a really good service. And I think it's really important that you know that that's happening, because we do signpost a lot of patients, and it's really good for our receptionists to feel confident they can refer through to a service like you. So I just wanted you to know that, because I think it's vital.
Thanks. I know I've got a few people wanting to come in, but I've got a question, which is for all of those numbers that you were showing us, you know, the number of people that you'd spoken to, the number of volunteer sessions that you were doing, how many people are involved in the Nuke? So what's your staff base and your volunteer base?
So we have around about 10 employed members of staff. And about the same number of volunteers. Our volunteers fluctuate up and down. Every time I go out and do an awareness campaign in the community or
not just me, but our volunteers, people come forward and offer their services. So yeah, it continues to grow.
Great, thank you very much. And I think, Jackie, you were next.
Hugely moved by your story, my neighbour. Your call to action, I was just thinking about what could I do apart from being aware, but I'm involved with the Perth and Kinross Credit Union, and an awful lot of the people who use the credit union are people who largely are struggling to get bank accounts in other places, and poverty is a big impact. And I would quite like some details of your service that we could put in the credit union and maybe stick on the walls, maybe even put a wee bit on the website, if that would be okay. And I wanted to say thanks for that lovely presentation that was just so well done. Actually, it was just really well done. It just hit the spot. And how grateful, you know, for your service. Thank you.
Sam.
Well, can we replicate you some way? I mean, it was wonderful. It was really good. It makes me remember why I do what I do. But one of the things I was wanting to ask is about your model. Is this a model that you've replicated from someplace else that can be replicated somewhere else? Or is this something that you've created and evolved yourself? I'm just thinking, you know, they've got a similar type of facility. I don't know how similar it is in Angus, and they've just opened up a drop-in crisis service in Dundee. Have they worked with you to try and look at the model? So can we expect something across Tayside that's half as good as yours? Thank you.
So I'd like to see it across Tayside, but I'd like to see it across Scotland as well. And yes, we have been working with neighbouring local authorities and recently Falkirk and Stirling, and had some input into Hope Point and Dundee, and presently working with Angus. The model has evolved around the presentation of the people that have been coming through the service, and we've continued to expand, develop and grow. As I said, we had some development sessions this year and staff focusing on some of the presenting issues that we were seeing. And we've looked to neighbouring local authorities, so when we have had faced challenges, it's been trying to make connections to find out what's there. So we have reached out to some clinical colleagues within the room for advice, and within neighbouring local authorities to say this is a presenting issue, how is this dealt with, and you know, how would we manage to deliver something within the NUC. So no, yeah, across Scotland.
I might catch it afterwards. I'm work with a mental health charity in Stirling, so interesting to catch up with you. Thank you very much.
Thanks for the presentation. That was really inspirational, both of you. And it's an amazing project where it's non-judgmental and it's a talking therapy, and it's about being supportive and allowing people to find their needs, and they've got their own answers. See if you talk out loud to other people, you'll hear your own answers. And that's what I was hearing there. I've got some similarities in a program or a recovery program that I'm on, but I just found, I really hope it takes off. I really do hope it takes off across Scotland, because it's the answer. And what I do really hope too, that the funders are only looking for soft indicators at the very most, that they're not needing to tick boxes and tick this and get this number and that number to satisfy the bean counters.
We'll come to David next, and Bob and Sheila.
Yeah, thank you for a very moving presentation. From a bean counter point of view, where do you get your money from? Who's paying? And
so
we did get some money from the Health and Social Care Partnership earlier this year, National Lottery and a lot of local trusts. So a huge part of my time is about always seeking funding and next steps, and Ganachie as well. So we were part of the symposium day, and you know, we are hoping at some point in the future that Ganachie will look favourably on an ongoing application or an ongoing funding for ourselves.
Thanks very much, both of you. That was an excellent presentation. And in my own experience of visiting Nuuk, I remember one person saying to me, it was life-changing, life-saving, in fact, was the terms that she used. So I was very taken by that, the immediacy of it and the openness of it, that welcome people in. And that part of the model is totally replicable elsewhere. I suppose one of the questions that I was going to ask is that this works really well in an urban community where it's very easy to get to this place. Have you any advice or ideas on how we might think about this in more rural areas, for example, where it's difficult to get that head of steam, as it were, of the numbers of people who'd be able to access service for all the range of reasons that you're familiar with. I just wondered what your thoughts might be on that, both of you, actually.
Carry on. Thank you. So we do reach out to the rural community. We can offer telephone support and video conferencing, and we will pay to bring people into the service through a taxi. But you're right, there is always much more work that can be done in rural communities, but we are seeing referrals coming in from rural GPs. So yeah, raising awareness of the service is almost a 24/7 job as well. Do you have anything you want to add about rural location?
I'm so fortunate. I'm a 10-minute walk away. I don't know how people would get. If I lived rurally, I wouldn't be able to get access to service, but confident that there's telephone support and video support, that would be helpful, but it's always better face to face.
Oh, thank you very much. I'd just like to echo all the thanks that you've received so far, and how valuable, just to comment on how valuable it is to hear directly from you as a provider, Wendy, but particularly you, Shirley, in terms of your experience of lots of different services, because you spoke about being in Murray Royal Hospital and the importance of that, and how helpful that was too. And I think the single model that we spoke about earlier around, which is about helping people to go, receive that very specialist help when it's required, but also have access to support near to where they live. That you can walk in and that people will stick with you throughout, that is really important too. So hopefully you'll see that, and hopefully you'll be able to bring your own experience to bear in terms of how that evolves. Really keen to involve you in those discussions, because you're extremely articulate, extremely experienced in this, and we would want to pick up on that. I'm absolutely certain. Thank you.
Thank you. I probably should declare that I have maybe not a vested interest, but I've been in the Nuuk quite early on, when you first moved into those new premises, partly because I know people on the board of Lighthouse for Perth, which shares the building with you, but also because I know some of your councillors, more than one. But my main point is to say to anybody who hasn't been there, please go and visit, because the environment, I think, is hugely important. When you walk in there, you feel immediately relaxed. You know, I just sat in one of the nice armchairs and just felt I didn't want to leave there, and I just go in for a look. So I think that's a huge part of it, is the environment, and that's welcoming, and that people can sit for a while on their own quietly if that's what they want to do, and that's 24 hours. I think that's hugely important. And so I would urge anybody who hasn't been to see the environment themselves to that's okay, Wendy, to encourage people to go and visit, to go and see it. Thank you. Thank you.
Okay, thank you. I'm looking around and I'm not seeing any more questions or comments. Okay, thank you very much. Just to add to what Jackie said, it is really important that we hear, you know, not just the formal papers setting out a strategy or giving us statistics on an update, but that we actually hear how things work on the ground in terms of, you know, what the third sector is delivering, and also, as Jackie said, Shirley, you know, what people's experience of the systems and processes that is. So thank you very much again for coming. With the board's indulgence, I think we should have a recess until 3:30, and then we can stretch our legs and before we get into the remainder of the agenda, if that's okay. So 3:30. Okay, thank you very much. Welcome back to this meeting of Perth and Kinross Integration Joint Board. We've now got the Director of Public Health Annual Report. So welcome to Dr. Emma Fletcher. But I'm going to let the Vice Chair. What? Oh, no, I'm going to let the Vice Chair lead the discussion on this and the next two items on the agenda. So I don't know if you want to invite Emma to introduce the report.
I will again invite you to introduce your Director of Public Health's paper to the board. Thank you.
I'm honoured to receive the double introduction. Thank you very, very much. So hopefully the presentation will start to show. Brilliant, thank you. And we can move straight to the next slide. So hopefully this is incredibly pertinent given the earlier discussions of the IJB and builds on a lot of what we've been hearing already. For background, this is an annual report from myself, obviously, that describes the epidemiology of our current state of population health across Tayside. It is designed purposely to be a reference document. It's not here describing in depth all the work that the Directorate or the Specialty of Public Health is taking forward. There are summaries embedded in the chapter, but for the full in-depth qualitative reporting that goes up to the Public Health Committee of NHS Tayside, and the reports of that are online. But as I say, this is a reference document that is designed to highlight the key health challenges faced by the population currently, to describe and articulate the magnitude of some of these challenges, and also to highlight priority areas for focus that we are all very conscious and aware of, but to demonstrate the where we're at and the pressing needs around some of these still remaining. Also, just to say that the Director of Public Health Annual Report is publicly available. There's the link there, but if you Google it, it's easily accessible and there for everyone to download and use as required. Thank you. Next slide, please. Just start by giving a bit of context, and again, yourselves will know this, but I think it's always useful to reflect on who our populations are that comprise the Tayside area, and to note that Perth and Kinross are purple throughout the report, have increased in terms of population size over the past 20 years. So it has increased from approximately 135,000 up to 151,000. So that's an increased population of 16,000. And it's now the largest local authority size in Tayside by population. Next slide, please. For me, I think this is incredibly impactful. These are the population pyramids of Angus in green, Dundee City in red, and Perth and Kinross in purple. And what these describe are the age bands. So the number of people or the percentage of people in each age band in each local authority area, with males on the left-hand side of each population pyramid, females on the right each population pyramid. The largest population size in Dundee is the younger adults, aged 20 to 30 thereabouts, due to a very vibrant student population. But then you will see, and markedly in Perth and Kinross and in Angus, the biggest population cohorts currently are your 55 to 59 and adjacent age cohorts. And that's due to the increased birth rate that we saw in the 1960s. So this is really, really impactful, and this is what we need to be planning for going forward. Next slide, please. And also, so this is the projected population change in Tayside by local authority area for the 75 and over population. But to note, this is describing a 30% projected percentage change for your over 75s between 2018 and 2028. We are already halfway through that. And if you remember back to the previous slide, that's not even accounting for the 55 to 59 bulge that will come through in the next 10, 15, 20 years. And it's really important to plan for. Great to hear about the age-friendly communities, that the work that's been taken around of that, and that's going to be really helpful going forward. But again, it's just to really keep this as a key focus in terms of thinking about housing, social care, healthcare provision, all these key services and support that we need to put in place to support healthy ageing going forward. Next slide. In terms of life expectancy, I want to pull out a couple of things in this chart. So you will see that the solid lines are life expectancy for males across Angus, Dundee and Perth and Kinross, dotted lines for females across Angus, Dundee and Perth and Kinross. The overall trend is life expectancy is stalling and decreasing in some areas, and that is really stark to see, and as Professor Michael Marmot articulated with regard to similar statistics in England a couple of years ago, really should not be happening in today's society. Also, you will see that really stark gap between male and female life expectancy, and I think this is really important because there is understandably a lot of focus around women's health at this currently, and women's health is challenges and has different nuances, but we absolutely cannot lose sight of the impact and the huge difference in life expectancy for males as well. And also just to flag that whilst Perth and Kinross is in the position whereby it has the longest life expectancy of all three local authority areas, as we will see in the next slide, that is of a Scottish position, which is the lowest of the United Kingdom 4 countries, and the United Kingdom position, which is one of the worst in terms of life expectancy across Western Europe currently. So a lot of challenge around how we support and improve population health locally, nationally, and at a Scotland level and at a UK level. Thank you. Next slide, please. Just want to think a bit about the differences between health experienced by people living in greatest deprivation compared to living in least deprivation. And to note that some of the drivers of the decreased life expectancy is due to decreasing life expectancy, markedly more impacting people living in greatest deprivation. So this slide outlines a table looking at premature mortality, so causes of death before the age of 75. First two columns describing the most common cause of death for people living, of premature death for people living in greatest deprivation compared to least deprivation. And it's really, really important to understand when we're looking at this table as well, the numbers are far greater impacting for people in the first two columns compared to least deprivation. And you will see that the predominant causes of premature mortality for people living in greatest deprivation, substance use related, drugs, alcohol, and the impact of smoking still, and also with regards to mental health. In contrast, many of the drivers of premature mortality for people living in least deprivation are the malignancies. And as I say, the numbers will be far fewer in comparison. And I think it's really important to kind of pause and reflect on that, because as a health care provision across kind of nationally, internationally, much the bulk of our expenditure, be it treatment or research, is with regards to cancers, and it really is where do we need to be focusing our resources, our priority of attention, and again it chimes and echoes so much of what we have been describing earlier in this meeting. This slide shows premature mortality now in ages 15 to 44. And I think this is utterly devastating. So the orange line is the Scotland-wide trend, Scottish average. Again, Perth and Kinross is the purple line. And you will see that over the last 10 years, mortality in ages 15 to 44 has been increasing. For both Perth and Kinross, but also Scotland-wide. The main drivers for this concern substance-related deaths and also suicides. And these next two slides just describe those each in a bit more detail. So we know that substance and drug-related deaths have been increasing markedly over the past 10 years, and you can see that with the Scottish-wide average, but also the impact that we're seeing here locally, Perth and Kinross. And also, in terms of the next slide, is with regards to suicides, and then we've covered this quite extensively earlier in the meeting. But in terms of the Scotland-wide position, that is showing slight increase, but a really stark increase within Perth and Kinross for suicide harm. I'll also just point out that these are statistics to 2021, so it doesn't capture the initiatives and the impacts that have been taken forward in the past couple of years. And have been articulated in Chris's earlier report, and particularly with regards to section 4 in the item 6.3. So hopefully we will see that start to change over the next few years, but really, really stark statistics. I'm going to just pick up on alcohol related harm, because I think with a huge focus understandably around the increasing substance related harm, there has been kind of less of a focus of alcohol related harm, but that remains and continues to be considerable challenge for public health. If you took this graph back to the 1980s, you will see that the rate of alcohol specific related harm and mortality is far lower than anywhere that you have seen in that graph. So it was around about between 5 and 10. And then we saw a considerable increase in alcohol related harm. And then in the early 2000s, a lot of policy focus legislation around seeking to address the determinants of harm and improve our collective whole system response to alcohol related harm. That delivered some improvement, and you've seen the Scotland-wide decrease in the early 2000 to 2010, but that now has stalled. And again, it requires a collective refocusing on our efforts with regards to alcohol-related harm that we cannot lose sight of. There have been improvements, and I've picked out coronary heart disease, and this is a measure of hospitalizations, and we have seen a notable decrease in coronary heart disease hospitalizations over the past 20 years. And this has been predominantly as a result of the decreasing smoking prevalence that we've seen across the population, and is very, very welcome. And also the increased medical interventions and technical approaches that we can deliver in terms of cardiovascular care. But again, the decreases that we've seen in previous years is starting to stall, and it is very likely that we will see this start to increase as we see the impacts of rising diabetes, particularly type 2 diabetes, in future years. In terms of the current prevalence of diabetes across Tayside, approximately 1 in 16, 1 in 17 people have diabetes now, with 90% of diagnosis of diabetes being related being type 2 diabetes. And what's more is these diagnoses are happening earlier. So it increases the risk of complications in future years and increasing morbidity and mortality. In terms of the weight, next, yeah, perfect, thank you. In terms of where we are across Tayside with regards to weight, fewer than a third of the Tayside population now are considered to be of healthy weight, so that's a BMI of 25 under, and that's the significant driver, most important driver for type 2 diabetes, which arguably is for the majority of people a preventable illness. Just want to flag this because I think it exemplifies a lot of work and the impact of focused activity in the result of focused activity across the whole system. So this is percentage of babies that are exclusively breastfed at 6 to 8 weeks. And I completely understand and appreciate that for some people it's not possible to breastfeed, but for those that can, it is so beneficial for baby's health, maternal health, family health, and also it has crossovers to wider health benefits. And you can see that through concerted work that we've been doing, public health, third sector, health and social care partnerships, we have seen an increase, and I would say more so than over the Scottish average, although it is quite difficult to see, but particularly with young mothers and mothers living in greatest deprivation. And this will confer huge population health benefits going forward. So just to summarise, thank you, and I'm happy for you just to spin through these. Thank you. Key messages: life expectancy is stalling or decreasing, so we are not living longer. As I say, life expectancy is decreasing, particularly in areas of greatest deprivation. You will see that huge devastating impact of that premature mortality that we are seeing, particularly in 15 to 44-year-olds. There's a massive impact of socioeconomic deprivation, and that's described throughout the report in various data that's presented. I've highlighted the ageing population and the focus of effort that we need to think about how to support healthier ageing over the next particularly 10-20 years. We have seen successes, decreasing prevalence rates of smoking across the population, and that increasing rates of breastfeeding. But we have huge challenges still and persisting and increasing. Obesity is a really difficult one to tackle. It's about our environment. It's about how we our availability of processed food. It's about how we can support and make things make it easier for physical activity where we possibly can. Substance use, drugs, alcohol, and as I was discussing with colleague earlier, the huge concern about vaping. Just to reiterate, e-cigarettes are an adjunct to help people stop smoking. They should not be used as, when people have never smoked. And we are seeing really big concerns about the impact of vaping in particularly younger population, and what's now coming through primary care of colleagues seeing health consequences of that in a primary care setting. There's also the challenge around climate change and sustainability, and that's not included in the report because we just don't have the metrics available to describe that, but we're looking to do that in future iterations. So I'm just kind of finishing by flagging, I mean, the wider context is hugely important, both in terms of our environment, our landscape, both within Scotland, within the United Kingdom, and arguably globally also. But I think we also can't lose sight of what we can impact locally, and we've heard that earlier today. We hear that through our whole system working, that we're all part of the work through the community planning partnerships that are absolutely integral to this. And as I say, I just hope that this report is helpful in providing that context. being used as a reference tool to advocate for change going forward in whichever setting we are, and to keep our mind focused on the key public health challenges we face. Thank you, Chair.
Speaker, thanks.
When I look at the figures, it seems to me that obesity is the thing that's driving the decline in life expectancy, and I'm not really sure what the answers are. Do you have any answers?
So actually, at this moment in time, it's more around substance use, drugs, alcohol, and mental health that's driving the decreasing life expectancy, and again, particularly for people living in greatest deprivation. I don't think we've yet to see the full impact of the morbidity and mortality associated with obesity coming through the system yet.
Martin?
Thanks, Emma. It's a great report. On the obesity and the vaping, is the tobacco industry behind vaping?
So that's an area with my technical expertise. I think I am aware that there is a crossover, and I think what is very difficult, well, actually, if I take a step back, the World Health Organization in their approach to alcohol, the main drivers of alcohol consumption are availability, accessibility, attractiveness, affordability. And I would argue that that applies to every substance. So, so with regards to vaping, how affordable they are, how available they are, what measures are in place to restrict access or otherwise, and also what their attractiveness is. And that's really one of the big patterns that drives substance use of any description. So I hope that answers your question in part.
Partly it does, and it's just that the big lobbyists that will be behind the tobacco industry, behind the vaping and behind the alcohol, and the obesity with the food, the big food. That's how we deal with the big beast.
For questions? Emma, Bob?
Thanks, Emma. I think for me, it was looking at the increasing death rate into 15 and 40 odd age group struck me. But also, as you said, the biggest issues we're dealing with are around mental health, drugs and alcohol. So they strike me as the target area. So I suppose my question is a fairly broad one, is about how does a public health approach that you have in NHS Tayside, how will that work to improve population health for Perth and Kinross around some of these key areas we're talking about? If we take mental health, for example, because that seems to me to be how do we make sense of this? Because this is everybody's business. It's not just a health issue. It's much more about all the other factors. And how would you see the role of councils and the role of the Health and Social Care Partnership within the integration scheme, which is about health promotion? How would that work for us here?
Yes, absolutely. And when you started saying the public health approach to the NHS Tayside, and then segued into everyone's challenge, that absolutely is. I mean, we as a specialist function can provide the public health leadership in terms of the advocacy work around this, bringing the data and understanding what opportunities there are for intervention. But that public health approach, that is early intervention, that's prevention, that's reduction of inequalities, that's evidence-based where at all possible, although some areas don't have the evidence base behind them, it is so critical. And I think whatever stage kind of whether it's community provision, whether it's a focus on your housing strategy going forward. I mean, anyone's housing strategy going forward, and we've supported and helped Perth and Kinross colleagues around that. Because they, with regards to housing strategy, thinking about physical activity, thinking about green spaces, sustainability, climate change, through to social care. How do we plan for the next 20 years? What does care home provision look like? Through to health, when we're engaging in whatever setting, how do we take the opportunity to work with people to think about what behaviour we can nudge, and not everyone's going to be in a position that they are able to make a difference, but at the same time I don't think we can underestimate the impact that we can have as health and social care professionals, saying, have you thought about cutting down your smoking, cutting down your alcohol? It can make a small difference and cumulatively drive change. And then there's the things about, well, how do we plan for those that we can't change or influence? And for me, some of the thinking around, for example, prostate cancer, which we know increases with age, is going to change in the next 10, 20 years. We are going to see a greater incidence of some age-related conditions. And actually, what does the planning for that provision looks like? So I think having the opportunity to talk in these forums, bring it to everyone's forefront of their mind, and so that they can take it back into their areas of work and go, right, we need to think about that. Next planning meeting, next thinking about public transport. Well, how do we support people to live in more rural areas for longer? And what does that look like? So just having this opportunity is incredibly valuable. Thank you.
Colin?
Thanks for the presentation. I was particularly interested in the fact that you had singled out the breastfeeding statistics. I had a very useful and interesting conversation with Janet DL and one of your other colleagues a few years ago now about the breast bodies model. I'm not sure that you quite got the airtime you needed, but I think it would be really useful if you could sort of outline the range of benefits that come from that, both health-wise and developmental, but also over the long term rather than the short term, because what we were talking about earlier, for example, was about early intervention and prevention. And I was struck by just how great an example of a small amount of spend in this case could reap multiples in future.
Yeah, completely. And it is one of those things that's right at the start of someone's life. And it's so good for so many different reasons, not just supporting the health of the infants, the babies, in terms of protection against diseases, the health of the mother, in terms of that bond, that growing as a family in those early stages, and also the benefit for mental health. But also, I think in terms of the huge concerns we have around child poverty as well, this is something that families can do that doesn't cost and is so beneficial. But I do need to stress that for some people it just is not possible for whatever reason, and I don't want anyone to be stigmatized for not breastfeeding, but I do want to make sure that the people know that there is support out there, and that we live in a society that's fully welcoming and accepting of breastfeeding in public, in businesses, in workplace settings, and yeah, they're really critically important.
Thanks. Hamish, got a question?
Yeah, I just want to pick up on David and Bob's comments about the drivers to some of the ill health, and we do have a drug and alcohol strategy. We've got a mental health strategy. We don't have an obesity strategy, and I recognise it's everybody's problem, but then it becomes nobody's problem. I'd be interested to know, perhaps from Emma and others, what is the HSCP's roles in this? I know Emma and I have had a number of conversations about how can we as an HSCP and IGB get more involved in that. I'm always struck by T-shirt I bought in Australia many years ago, which says "Be the change you want to see in the world," and I try and keep that in my mind. And we have got a very big lot of we employ a lot of staff, and maybe that we maybe need to think about a twofold strategy about public, but also how our own teams, how do we support our own teams to have these healthy lifestyles, and particularly around obesity. It's not just about diabetes, it impacts on mental health. I see so many patients with osteoarthritic problems with their knees and hips day in and day out, and it's all driven, substantially driven by weight excess. And I'd be really keen to understand from Emma and others, how can we as a partnership engage in this in our strategies and our prioritizations?
No, I think it's a really critically important point, and I think what would be really helpful is to set aside some time and think about all the various elements. Because what describes is, yeah, absolutely. How do we support our staff? What are our policies? What is the environment? What food is available? How do we support active travel to work? Do we have shower room facilities? Do we support people to leave their desk for half an hour at lunch and get fresh air? I'm not sure that we necessarily, and I'm just reflecting on how I ate lunch today, do that routinely or prioritise that through to how do we plan housing, how do we plan schools, how do we prioritise healthy eating in schools, how do we prioritise physical activity, and particularly for young girls, because we know that physical activity drops off markedly throughout secondary school for a number of different reasons. So yes, I think that's something we need to work on, and I'm happy to do so.
Mine's not a question, but it's more of a suggestion that, we are midway through our strategic commissioning plan for the IJB. So that was a 2020 to 25 plan, and we're going to extend that to 26, but take the opportunity, and Zoe's just going to present something shortly around where we are with that. But I think that presents an opportunity to pick up on some of the questions that you've been asking there, Hamish, about how do we make sure that we've got the public health messages or key issues for Perth and Kinross right through the middle of that strategic commissioning plan, and we're clear about the messages both inside the IJB but right across all our partners. I think that would be a real ambition to take forward, and we've got an opportunity because that will be coming shortly in the new year. Thanks.
It's just really picking up on Jackie's point, actually, in the strategic commissioning plan. As Jackie will know if she puts on her other hat, the Perth and Kinross Council identified 7 key priorities last year that they're working towards, and while none of them specifically mentioned public health, I think that there's a huge, and I've said this before at Health Board, means that there's a huge responsibility on councils to deliver some of this, as opposed to the Health and Social Care Partnership themselves. So Jackie, maybe it's something to work with, perhaps some of the senior officers and Aaron, when the new chief social worker comes on board, to try and make sure that all of the priorities across both the councils and Health and Social Care Partnership and the Health Board are all aligned. So at least we can see a read across, and not, even more importantly, not just aligned in terms of the principles, but also in terms of the timing and the priorities that are given to the various interventions that are being made. And the only other point I would probably make is I go back to what I said before, children and what happens in schools is vitally important on all of that, because the early years in childcare in particular is a good opportunity to do that. Unfortunately, most of our children across the whole of Tayside get frozen school meals, which is a real shame, because that's basically, in my view anyway, telling people that that's how you get food, and so they don't learn about where food comes from or how to prepare it, etc., etc. That's a totally different argument. But I do think, Jackie, that might be something worth considering when we're doing the strategic plan. Thank you, Chair, Vice Chair.
Any other questions? Do we really need these things? Any other questions or comments other than mine? No. We talked tangentially about poverty, but actually you were quite clear that the difference between people living in quite impoverished areas and people in less impoverished areas is significant in terms of mortality. Actually, when you see the graphs in terms of drop-off, how things have got worse, and you mentioned the last 10 years, and I just wouldn't really want us to leave your report without actually thinking about the impact that poverty is having on our communities.
No, it's absolutely stark. I mean, it's why we have a task force meeting upstairs at the moment. It's why child poverty absolutely has to be a big focus. I think I would just kind of flag though that the socioeconomic deprivation markers also encompass other elements of deprivation. So it's not poverty is an absolute critical driver of that, but it also takes into account accessibility to other amenities, how well served community areas are. And we also understand and recognise that the SIMD markers, the socioeconomic deprivation markers that we work to, don't always necessarily take into account the impact of rurality, which is also a huge challenge for areas of Perth and Kinross. So, but yeah, through all of that, absolutely poverty is a huge driver of ill health, and the widening inequalities that we're seeing in wealth are undoubtedly causing the health inequalities that are growing currently.
Or thank you. You could be my button toucher. This report was presented to us for awareness. And as Emma said at the start, there is a Director of Public Health full report that people can click on if they want to read it in detail and see that in all its fabulousness. So thank you very much, Emma. And if we move on to the strategic commissioning plan update from Zoe, please.
Oh, okay. Okay, so the purpose of the report that you have in your papers is to provide the IJB with an update on the progress of the development of the refreshed strategic commissioning plan. So as you'll be aware, each integration authority must produce a strategic commissioning plan that sets out how they will plan and deliver services for the area over the medium term using their integrated budgets. Stakeholders must be engaged in the preparation, publication and review of the strategic commissioning plan in order to establish a meaningful and co-productive approach and to enable integration authorities to deliver national outcomes for health and well-being and to achieve core aims of integration, which are to improve the quality and consistency of services for patients, carers, service users and their families, to provide seamless integrated quality health and social care services in order to care for people in their homes or a homely setting where it's safe to do so, and to ensure resources are used effectively and efficiently to deliver services. As part of having a strategic commissioning plan is also a requirement to review said plan, and this must be done every 3 years. You can carry out reviews in between times. In carrying out a review of the strategic commissioning plan, integration authorities have to consider the national health and wellbeing outcomes, the indicators associated with them, principles of integration and the views of the strategic planning group. A review may result in the integration authority making necessary changes by replacing its strategic commissioning plan. So Perth and Kinross already have an existing strategic plan 2020 to 25, and it was developed in 2019, which was pre-pandemic, prior to the Feely review and before the announcement of proposals for a national care service. So as the landscape's changed markedly since then, and so much of what's now been delivered by the HSCP has been heavily influenced by the pandemic, it was proposed that we revise said plan. So in order to do that, we've undertaken a range of activities over a period of most of this year, really. And the first piece of work that we undertook was a joint strategic needs assessment, of which there is a draft copy. It hasn't been sent out with your papers, but can be sent out after the meeting. And the purpose of the joint strategic needs assessment is to provide a clear understanding of health and social care needs of our local population, and it brings qualitative and quantitative data together on health and care needs, and creates a full picture of service needs now, in the future, and supports strategic planning decision making within our partnership. So we've pulled out some of the main GSNE findings or highlights from that. Very conscious again of coming after Emma. There is a plethora of information that sits within the GSNA, and obviously the public health report that you can read if you want more detail on any of this. But the things that we've chosen to highlight today are that the majority of Perth and Kinross population live predominantly in rural areas, so 68% of the population. When we were looking at dependency ratios, which is the number of people over the age of 65 per 100 people below the age of 65, this ratio is higher across our north locality, followed by south locality, and with Perth City having the lowest dependency ratio. There are particular villages like Comrie that have very high dependency ratios. Dependency ratios give us a really good indication of the likely need for health and social care services to support people in those areas. As is well rehearsed, Perth and Kinross have a higher proportion of people over 65 than the Scottish average, and our north and south localities face greater challenges in relation to that ageing population. Perth and Kinross have a smaller proportion of people of working age compared to Scotland as a whole. In terms of our carers, it's generally split reasonably equally across the three localities. North and south have slightly higher numbers. The highest proportion of carers across all localities are in the 66+ age group, and the majority are female. With regards to our learning disability population, the life expectancy of people with learning disabilities is increasing. However, it remains shorter than the general population, and the more complex the condition, the lower the median age of death. This is based on national data, so our local data isn't as robust as we want it, and we're going to do further work on this at the moment. People with autism experience poorer mental and physical health and may be more likely to die younger than their peers without autism. Perth City locality hosts the majority of deprivation for Perth and Kinross, with 5 areas being in the most deprived quintile, equating to about 16% of the population, which is an increase of 2.6 since 2016. Perth City also hosts the most affluent proportion of the population, with 27% of people living in the least deprived quintile. So there's a sort of polarisation in terms of that population, which is interesting in terms of thinking about the health and social care needs of the city comparatively. Perth City locality has more people suffering alcohol and drug-related harm and ill health than the other localities. And when the SIMD is broken down by domain, over 40% of the population are in the most deprived quintile for access to services. For the north and south localities, accessibility is the biggest issue, with over half of the population in the top 2 most deprived quintiles. Our ageing population will change demand for housing. This population are also more likely to live alone, for houses to be under-occupied, increasing risk of isolation and loneliness. In Perth and Kinross, 21% of the population who had contact with NHS services had at least one physical long-term condition. And of this population group, 17% of those under the age of 65 were living with more than one long-term condition, compared to 50% in the over 65 population. Projections indicate also a requirement for an increase in care home placements year on year. Falls are the most common reason for admission to hospital, although the data doesn't identify individuals who've had multiple falls, so there's a bit of caution in regards to that one. In Perth and Kinross, the leading cause of dementia for females in 2021 was dementia and Alzheimer's disease, and was the second leading cause for males. And in Perth and Kinross, it's estimated that roughly 3,350 people are living with dementia. Perth City locality has the highest number of unscheduled bed days. Most of the unscheduled bed days are for the over 65 group. Perth City has the lowest over 65 demographic in comparison to north and south locality though. Post-COVID, there has been an increase in delayed discharge across all localities, with Perth City returning to its pre-2017 levels. Again, I would exercise some caution in and around that data, because during COVID there was some very unusual behaviour in relation to discharge. Psychiatric hospitalisations or admissions in all localities have seen a steady decline. However, there is a fairly significant disparity between Perth City and the north and south localities. So on the basis of that GSNA and the data that we pulled out, we went to localities and presented some of that high level data to people to speak to them about what the needs were, within Perth and Kinross, and therefore what the people who live in those communities felt in response to that. We've been really focused in regard our methodology, regards our consultation, and have stressed that active involvement of the community plays a really pivotal role in driving the transformation of our health and social care. That we're committed to fostering collaborative relationships with individuals and communities, and that we really place a very significant importance in actively seeking the input and feedback of those who access our services. And in order to do that, we've used national guidance, the 7 national standards for community engagement, and the planning with people guidance from Scottish Government. So the aims of the consultation were to involve people in shaping the future of health and social care services, to develop a better understanding of what matters to people, and to inform people of the challenges facing the health and social care partnership, and to seek their views on what did they feel, think and want, what needs to be changed or improved, how things could be done differently, and to provide a wide range of opportunities for people to engage with the consultation on the development of the plan. We asked some very specific questions in our survey, and we asked people to rate how important specific aspects of health and social care were to them, and the following that come up in that slide are in order of importance. People felt very strongly that it was important to them that they could access all health and social care support in one place close to home. They had clearer and accessible information about the range of support and services available and who to contact for help. More opportunities to support health and wellbeing in their own community, provision of opportunities for local communities to influence how health and social care budgets should be spent. People should get out of hospital more quickly to be supported at home, supporting more people to stay at home through better use of technology, a more consistent and regular opportunities that supports carers' health and wellbeing, quicker access to health and social care support through telecare and internet, and support for more volunteering or peer support as safe alternatives to services. We asked people about challenges that they experienced, and you can see in that chart that access and distance to service was rated as one of the biggest challenges for people. Not surprising, I suppose, given the rurality. Finding time to attend appointments was an issue for people. Knowing where to go, access to information, finance, money, caring responsibilities, transport and relationships with professionals were all stated as challenges. We asked about satisfaction levels in relation to their access to health and social care. 49% of participants said that they were either satisfied or very satisfied. 20% said neither satisfied or dissatisfied, with 14% specifically commenting on what they were dissatisfied or very dissatisfied with. So there were some very clear messages consistently being fed through all forums and methods used during our consultation. People are clearly saying that they want access to support in their own communities where possible, and that having access to multidisciplines in one building would be preferable. People were clear that they wanted to be involved in the planning and design of how services were delivered. And of the 14% who were dissatisfied, it was commented that the areas of challenge were distance and access to services, waiting times and delays in support, a lack of joined up working between services, quality of care and support, and having to repeat the same story multiple times. We ran additional sessions for our workforce, and we felt that that was really very important post-COVID, and acknowledging the impact of that psychologically and emotionally on that workforce, and what it is that they need or felt that they needed to continue to provide the support that they do. The workforce fed back to us that their main wishes related to improvements in service design, partnership working and systems being valued, and the need to increase resources. Lack of staff and resources was identified as their main worry, along with how they were communicated with, therefore how we deliver services. So being involved in that design and planning. There's uncertainty around the impact of the National Care Service for staff. They discussed improvements in terms of the relationship with primary care partners, and opportunities for how this could be improved further. They felt there was a lack of information on and understanding about services and roles, and they felt that that was a significant barrier to early intervention, and working with communities was really viewed as essential for future planning. We talked to them about unscheduled care, and they raised concerns in relation to discharge planning and inconsistencies in approach, which staff felt was due to a lack of understanding about key roles and services. There was a broad agreement, of course, that hospital settings not always the right place for people, and that the workforce indicated a need for a range of different community approaches with well-trained staff as key to supporting people to remain or return home. And they identified 6 themes with regards when we asked what matters to you. So increased integration of services to support partnership working. Ensure we have the right services in the right place and that people know how to access them. We need to consider a range of approaches to improve time efficiency for social care workers moving between appointments. We need to promote and value volunteering within communities. That continuous feedback is very important to staff, and that a sense of feeling valued was important, where the contribution is noted and understood. We then went on and had a further session with the Strategic Planning Group. We had 2 sessions with the Strategic Planning Group and then a joint session with the Strategic Planning Group and the IGB. And we took examples of priorities from strategic commissioning plans across Scotland and asked the question about whether the priorities in the existing strategic commissioning plan were the right ones or whether we needed to look at other options. And the priorities that were pulled out from that session were priorities that sat within Dundee and Fife's strategic commissioning plans were the ones that were seen as the most valuable at this point in time, certainly. Inequalities was highlighted as being something that we needed to prioritise, and targeted approaches to inequalities, not a broad statement about inequalities. That concept of having an open door, improving ways to access services and supports, making it easier for people to get to health and social care was really important. Working and planning together, planning services to meet local need, working with the communities to design the health and social care supports was highly important. And workforce, valuing the workforce, supporting health and social care workforce to keep well, learn and develop. Fife's plan talked about keeping things local, enabling people to thrive in their own communities, that it was sustainable and will ensure services are inclusive and viable, that well-being was important, and we needed to intervene early, which is a priority in our existing strategic commissioning plan, and you'll find that in the majority of strategic commissioning plans that were developed in and around 2019. And the outcomes, of course, were important, that they will promote dignity, equality and independence. And finally, integration. We will strengthen collaboration and encourage continuous improvement. So from that joint session and beyond our discussion on the current priorities and what was relevant now, the joint meeting confirmed that it's important we establish within the strategic commissioning plan a narrative which is outcome focused, an approach that is measurable and that delivers results, and that to do so then we needed to consider a time frame for the plan. We need to think long term, and although it's a 3-year strategic plan, its priorities will continue beyond that. We need to use language that isn't deficit based and that is focused on improvement, and that a co-productive and innovative approach in our communities is essential to to achieving a shared understanding of where we are now and where we want to be moving forwards.
Thanks very much, Zoe. Have we got any questions for Zoe on the report? We have one here.
Thanks, Zoe. That's a very comprehensive overview of the report and good content in it. I think the question I have, it's kind of leads on to the comment I made before about the role of local authorities in this. And I'm just wondering what engagement you've had with the service areas in the local authority, because they will have a contributory factor. For example, I think you mentioned transport was in one of the contributing factors, but accessing support and also around where people can access services in terms of locality. And as you're probably aware, it was certainly in Perth and Kinross, there's a property review going on. It was announced at a recent council meeting. So I'm just wondering, because I mean, the council is part of the partnership, and I'm just wondering what engagement they've had in this.
Certainly, the invite to all of the consultation was open to all partners to come to, and particularly the SPG session that we ran within Puller House, people were welcome to come along to that. However, I suppose what I would say is there are initiatives and opportunities in there, things along the age-friendly communities, for example, where we'll be engaging really heavily with our partners. We won't be, the HSCP can't lead in this, we are just one partner involved in that aspect of work. And I think the strategic commissioning plan will identify key areas like that where that joint working is absolutely essential, and will lead into the priorities that you referred to earlier on. For example, I think there's very little that we can do as a standalone in here. It's going to be dependent on us working collaboratively. And as you've heard in that feedback there, I think our workforce are very much on board with that perspective as well, that we can't do it on our own, that we have to do it in partnership. So although we've undertaken a considerable amount of consultation to date, as we move forward and as we develop strategies and continue to look at the delivery plans that we already have in place for older people, etc., we will continue that engagement process. So it won't be a one-off, it will be an iterative and ongoing approach that we take to this.
Just think our new chief social worker is going to be very busy when he arrives. I'm not sure if he knows about his inbox yet.
Can I maybe just come back on that? And that, because I think that Zoe, there is a plan to ensure that we've got the new strategic leads engaged in the discussion around this across the kit, because that's part of their role, is about the cross-cutting themes that they're responsible for. So engagement on this is really important.
Firstly, it's fine to see that 5 strategic commission plan was regarded, because I was involved in creating that. But see, the bit that me at 20% said transport was a challenge for them. I find that quite low. 20%. Is that 20% of people in deprivation areas, or is that 20% of people in rural areas? Because I'm more perturbed with 30% find the time to attend was a challenge. So the opening times are not right.
Yeah, no, it's a percentage of the people who responded to the survey, not the entire population. So we're not able to get the entire population's perspective in that. But consistently, as I say, through all methods of consultation, transportation was one of the biggest issues for people. And there have been reductions in bus services in rural areas, etc. If there's been closure of specific services, transportation to alternative services was highlighted, for example. Yeah. And part of that's the nature of living in a rural location, but also part of that's about that Perth-centric approach to the development of services. And so what we need to do is be looking at developing services or hubs in smaller rural locations that overcome some of those issues for people, and working with communities to do so as well. And as Jackie referred to earlier on, the work that we're looking at with the Trust, for example, is a really good example of how we can create initiatives and services in a different way that aren't just about commissioning a provider to deliver a service, for example.
Yeah, I was just thinking of the old community library buses again. So we use them as health buses.
Thanks. It was really just to say something in response to Martin's question about the response rate and around transport, because we're currently well, you'll know that we were carried out the primary care premises survey, and that's being independently analysed at this point in time, and there's likely to be some data in that will help to illustrate this further in terms of people's access to primary care services.
Thank you. Is there any concern about social care workers effectively butterflying, spending 15 minutes with one client, rushing off to another client and spending 15 minutes, but not actually delivering any sort of interpersonal care? Is that a concern?
So that would be relevant to care at home delivery, very specifically that time and task type approach. And we've been working very hard with providers to avoid using 15 minutes. There's occasions where 15-minute visits are fine and people don't want you in their home for any longer than that. But we work very, very hard with our providers to encourage a reablement approach to what they do. So I'm not hugely concerned about that. However, we have to monitor that in an ongoing manner to ensure that that doesn't become the case because of the pressure to pick up packages of care, unmet need that we have. And there is a balancing act in there about cramming in more visits or providing the quality of care that's required. And we're quite clear that we need to be providing the right quality of care, because ultimately if we don't, people will come back in through a hospital system, and that's not what we want to happen. So there's a balance in there, but we work hard at that.
The purpose of the report is to provide the IJB with an update on the progress of development of the strategic commissioning plan, and the recommendations are to note progress to date and the update, to note that there'll be a first draft of the strategic commissioning plan presented to the Integrated Joint Board on the 14th of February next year. Thank you, Zoe. But before you go mentally from this item, Serene's not online. So could you pick up the comments that Serene was going to give following the Tayside primary care strategy, please? Thanks very much. Okay, thank you. So we'll move on now to the Tayside primary care strategy. And I see that David Shaw's there. Is Sally with us too? Yes, she is. Well, that's smashing. So Sally Wilson, who I believe is the Integration Service Manager, and David Shaw, Medical Director for Primary Care. And have we got somebody else as well? See a third person.
Yep. Debbie McGill, our Primary Care Services Manager.
Excellent. So we'll now have the Tayside primary care strategy, please. I'll leave you to decide who's coming in on it.
Thanks. I'll come in first and then I'll hand over to Sally. So thank you very much for hearing the Tayside primary care strategy. I think primary care is a very complex but also vital component, the care that we provide to our population. Complex in as much as we're talking about 4 contracted streams that work across Tayside with 3 partnership areas embedded with social care, third sector, and interfacing across secondary care and out of hours. So it is also the first point of contact that patients usually have with their health concerns. And I think a functional, effective primary care that's close to where patients live within their communities, that can be relied on to provide top quality service, is really what we're all looking for. Now I'll pause for breath and pass over to Sally, who can discuss where we are just now in describing the strategy for taking this forward over the course of the next few years.
Thank you very much, David, and thank you, Chair, for inviting us to come along today. So I'm really delighted to be able to bring an update in relation to the progress that's been made to produce a Tayside primary care strategy. As you may know, it's been presented to both Dundee and Angus IJBs, so I'm really pleased to be here today on behalf of Jill Galloway. So the development of the strategy, it's really important to clarify that this is a collaborative effort between the 3 health and social care partnerships, NHS Tayside and wider colleagues. And it's really about how we support and enhance primary care across Tayside to ensure that it's high quality, accessible and sustainable. Now, it's important to clarify that when we're talking about primary care, that we're referring to general medical services, or sorry, general practice services, primary care out of hours services, pharmacy, dental and optometry services. So members will be aware that Angus IJB has the responsibility for the strategic planning and coordination of this strategy. And we're really keen to see how this aligns to the national health and wellbeing outcomes and indicators. And of course, as David has just said, primary care plays a vital role in health and care systems and is absolutely essential for local communities because most people in their lifetime use a primary care service. Of course, we know about some of the challenges that are ahead of us, especially from a workforce perspective across a number of different professions, as well as an increase in demand. But we've really wanted to take a joined up approach to developing this strategy. And in August, a session took place with key stakeholders, really to look at how we could pull together their thoughts and ideas regarding the strategy. And these have all informed the plan on the page, which is in front of you. So the first principle of the strategy you'll see is person-centred care. But as discussions are progressing nationally, it's really about person-led care and how we can support and develop that. So we will be amending the reference to person-centred care to person-led care. Another really positive step is that we had a meeting in October with NHS Tayside Public Partners, and we discussed the plan on the page and the direction of travel for the strategy. And it was a really insightful session. And the partners told us that they liked the content of the plan on the page, but they made suggestions about the layout. And so we've taken that on board, and we will be amending the layout, and it now includes, or will now include, the description that I provided about primary care, because when we say primary care, most people just think of GPs. They don't think of the wider contributors to primary care as a whole. And they've asked for it to include 3 reasons why primary care needs to change, so to add a bit of context, and also to include information about how we'll know that it will have made a difference. So by way of reassurance, we have consulted with members of the NHS Tayside Primary Care Board during the creation of the amended version, and they have provided input for that. So evidence of progress to deliver the strategy will be demonstrated through the National Health and Wellbeing Indicators, as I've just mentioned, but also key performance indicators will be developed. And one of the areas, going back to the meeting we had with public partners, was that they emphasised the importance of communication and really asked for examples of how to access information which supports people to take more of an active role in improving their own health and well-being. So the intention is to bring back the final draft of the Tayside Primary Care Strategy to IJBs for approval in February, following a period of engagement. And we will, of course, need to look at how the strategy is implemented and made meaningful in each partnership area. But last but no means least, I would like to thank everyone who's been involved to get to where we are now, in particular yourself, David, Gillian Galloway, Debbie, who's on the call, the primary care managers across the 3 health and social care partnerships. And of course, it would be remiss of me not to mention Gail Smith, who's now retired, who has really been a driving force to get to where we are today. So I'll pass back to David.
Thank you very much, Sally. I guess it would be useful, I think, for the IJB just to reflect perhaps a bit on the bit where IJB directed partnership delivered services interact with primary care strategy. So there's been a significant investment through the 2018 contract for general practice, particularly in patient-facing services that help to improve the sustainability of primary care. And I think part of the strategy is to ensure that we can appropriately capture how that set of services fits in with an overall strategic direction. I think what's relevant for Perth will be a little bit different from what's relevant for Dundee and what's relevant for Angus, but I think there are similar key areas that we'd like to deliver on, which I think are the same across the piece. So I think the IJB will doubtless want to review the ongoing work that's done both in the 2018 contract and in the additional resilience work that I know Perth has led on, to see how that can best chime with the work that's been done in cooperation with the partnerships across Tayside in delivering this. And I'll pause now for questions.
Before we have any questions, Zoe, do you want to give Serene's feedback first? Thank you.
So our strategic planning group met yesterday and looked at the plan on the page and the paperwork that came with that, and the carers representatives on the group in particular had a few points that they wanted to ask today or to point out, and some of which you've answered actually in your presentation, but they were highlighting the difference in the three areas, obviously, as you've just discussed there, that they had concerns about how realistic the strategy was, given, for example, the reduction in GP surgeries within Perth and Kinross. They raised concerns regards transport in relation to that reduction in services. They had concerns regards our rurality and does the strategy address issues specific to this. They felt, the group as a whole, that the strategy was setting very high expectations, which was admirable, but are they too high and are they realistic? And there was an ask for, and a quote-unquote, honesty in what current delivery is, and therefore, given closures, how realistic could this strategy be? There was a sense that the care isn't at the level that they want it to be. So when it states in the report that we're going to deliver care where you need it, when you need it, and in the time you need it, it felt challenging for the group. That it's great to have a goal, but they felt that the engagement activity around that could be improved, and we're really keen to engage more in terms of the draft and what the final strategy would look like. And there was comment about, did they see Perth and Kinross within this strategy, which you've spoken about there, and just a final ask of how do we engage more in relation to this moving forwards?
I think those are all really keen insights into what the strategy might look like operationally for Perth. So I think you've absolutely got some gold there from that group. Just going over some of the points that they've raised there. I think resiliency across contractor streams is an ongoing concern. So that's not something that's unique to general practice. I think we've had challenges within dentistry as well, with it becoming progressively harder in some areas to get an NHS registered service. And I know that there have been specific areas within Tayside where similarly we've had issues in supporting our chemist contractors to deliver the work that they do. So I think in terms of honesty, I can certainly say that we have resiliency issues, and I think that's recognised already by the partnership. I think Perth led on the work that subsequently ended up with a Tayside resiliency framework so that we can chart where we have problems across the piece. In terms of rurality, absolutely, I think at the centre of the strategy are high quality services that are close to where patients live. I think it's has been an ongoing pressure to try and maintain the network of surgeries that we have across Tayside. Unfortunately, we've lost 7 surgeries completely in recent years, as well as losing some branch surgeries too. And I guess part of the strategy is to work out how best to mitigate that. I think that's in part action that takes place through the lead agency, through Angus, in part through the partnership, in part through working with other parts of NHS Tayside and with patients to try and make sure that we can maintain sustainability. That's been a significant amount of work to try and stabilise general practice particularly, but also dentistry through work through the public dentistry service. So I think in summary, I think good insights. I think we'd absolutely acknowledge that there are pressures. Strategy, I think, is part about saying where you want to go, in part acknowledging the challenges that exist in trying to get there, and in part understanding how you will know that you've arrived there, working out what those key performance indicators are. Sally, is there anything that you would want to come in with?
Thank you, David. Yeah, I was just going to say this, the plan on the page, of course, is really, really high level, very high level, and it's very difficult to get everything down on a plan on the page. It's just giving the kind of setting the compass, and there'll be definitely more detail within the body of the strategy itself, detailing some of the issues that you've raised, and it will talk about you know, where we are now in relation to primary care and where we want to get to, and it will also talk about the risks and how, as David said, how we'll mitigate these. But we do want to be as ambitious as we can, but similarly we don't want to set ourselves up to fail, but we do want to be ambitious and realistic.
Thank you. Do we have any questions? Sally, then Sheila, then Colin.
Hi, thank you for that. I'm just a quick query. I'm always really keen that strategy documents aren't just something that are high level and don't reflect what's going on the front line. I think they need to be usable documents that whether you're someone who's using the services or providing the service can recognise their aspirations in. So I'm just wondering what we've talked about stakeholders, how have you spoken to frontline staff and how have you collaborated with them? I know P&K did some, after their draft, did some fantastic work collaborating with frontline staff to get their ideas and their feedback. So I'm just wondering how that's happened within this document.
Okay, so we've had some initial feedback through the meeting, the stakeholder meeting that I described, but we've definitely got more engagement work to happen, and that will happen with the support of NHS Tayside communication team. And as I said, we have met with public partners who've given some really helpful feedback, but we've definitely got more to do. This is just setting the scene, and then we will have more information within the body of the strategy.
Sheila?
Thank you, and thank you for the report. I'm particularly pleased to see a plan on a page. It's one of my favourite types of documents, as people in the council will probably know. However, what's missing from it are any timelines. And in fact, from the report itself, there's no timelines either. And this report is the strategy 2024 to 29 progress update. We're practically in 2024, and I'm rather alarmed, to be honest, that we don't have any indication of when this report will be, when the strategy will be completed, and what the strategic delivery plan will be from that. And I'm not sure if that's within the scope of the work that you're doing or not. From a Perth and Kinross point of view, we have whole swathes of our council area where there is no GP service whatsoever. I'm sure you're aware of that already, but it's causing a great deal of alarm and distress to the residents of Perth and Kinross. And I think anybody, member of the public, looking at this might have expected to see something a little bit more substantive to address the particular challenges that we're facing. I know you said that there's many things that are very similar across the three council areas, but I think that even from the information we've had already today, demographics, for example, and population spread geographically is markedly different in Perth and Kinross than it is in Dundee. So that requires a different type of consideration when developing the strategy. So my primary question is, what is the timeline to complete this work? Not just the strategy itself, but also the strategic delivery plan, and when will that be presented back to us? Thank you.
And Colin?
Thanks. I similarly had a concern just about timeline because I think, Ms. Wilson, you said that we were doing more engagement at this stage. I'm noting from the front page that a final version is going to be brought back to the IJB for approval in February, which is just in 2.5 months' time, 3 months' time, 2.5 months, allowing for the Christmas holidays. So if we're still at an engagement phase with staff at this point, there won't be much drafting time left after that. You did also mention that you were going to include how will we know if it has made a difference. So I'd be particularly keen to see some performance measures included. I'd like to echo the point that Councillor McCall was making about the geography. We've spoken umpteen times in this meeting alone about the rurality of Perth and Kinross. The entirety of Dundee City could fit in a small portion of my ward, and my ward's far from the biggest or most spread out in Perth and Kinross Council. So there needs to be something which recognises the geographical differences separate from the similarities that Dr. Shaw, you mentioned. And this is a 2024 to 2029 strategy or strategic plan. It's therefore time bound, and therefore I would, when the final plan comes back to us for approval, I would be expecting to see time-bound actions, ideally smart objectives, which say who's going to do a thing, when it's going to be done by, what it's going to achieve, and set that out very clearly in the final plan so that we can monitor progress closely against it. And that's more of a comment rather than a question, but you might want to reflect on that as you reflect on.
Could you respond to both of those, please?
Yes, of course.
Very similar.
Yeah, absolutely. So in the body of the strategy itself, of course, there will be reference to the different populations and the demographics and the rurality of all the different areas in Tayside. So that will definitely be an important section of the strategy itself and will inform some of the actions that we need to take. I mentioned that in my report that we will be producing performance measures. We definitely need to have, we're aligning it to the key performance, the national indicators, and we will be developing performance measures, key performance indicators. So in relation to timelines, we are in the process of refining these, developing these, but we haven't got them on the plan and the page, but we could consider putting those on, but we just want to make this, as I say, the plan on the page really high level, that the body of the document will contain those timelines that you're looking for. David, I don't know if there's anything else you would like to add.
I think really just to say that absolutely we do understand that the three different areas of Tayside have three very different demographics. There are some crossovers, there are some very rural areas of Angus, perhaps mixed in with the sorts of market towns that are also present within Perth and Kinross. But Perth certainly is the big county, and it does have rurality to a greater degree than the other areas. I don't think it gets away from what we're trying to achieve, which is local sustainable services that are wrapped around about patients. So in terms of the sort of high level strategic thinking, I think that is similar regardless of whereabouts in Tayside you are. I think how you operationalise that and how you deliver that is different. And I guess the strategy is in part a high level thing that sits at Tayside, but it's also something that partnerships need to interpret, because not all of the implementation of the strategy is going to come from the lead partner. I think it's really important that we get that joined approach that we've tried to bring to this in Tayside into the implementation. So it's a partnership, I think, between NHS Tayside, Perth and Kinross, and all of those different contractor groups and all of those interested stakeholders in ensuring that we can provide something that's personal and of good quality in every part of Tayside. I think I froze in there, so I'm not sure if you got all of my words. Did you?
We did get all of your words. It was our machine thing that was the problem, David, but I believe we have a question from Bernie.
Hi, yes, thank you. It was really only a comment. I did put a comment in the chat to thank Zoe. She really did put across all of the points that the carerettes we did raise yesterday at the strategic planning group meeting, and that's much appreciated. One of the points that we did also pick up on was the fact that we do acknowledge that not all services are necessarily delivered by the GP surgery, but the fact is that to access any of these additional services are all via your GP. So with the number of GP practices that are closing in Perth and Kinross, that the impact that would have on individuals is really something that is of concern to us. Thank you.
That's a good point. There are a variety of services which aren't dependent on a practice building. So vaccination would perhaps be one which can be delivered in other locations. Although historically it has been delivered from practices, it's sort of moving. And I guess the locations at which services are delivered from does need to be considered. We've done things historically for many years in using a particular model. Maybe that model needs to change. If we don't have practices in all of the locations that we used to have practices in, then maybe we do need to consider more clearly how it is we distribute those services. And I think that's in part a primary care strategy issue, and it's in part a partnership decision as to how it utilises the premises that it has control over, delivering services that it directs. So I think it comes back to considering what the needs of the relevant population are to try and make sure that we're doing the right thing in the right place. And that may be a different thing from that thing that we've done before.
Yes, thank you, and thank you for your replies. One of the questions I did ask was, will the strategy when it comes forward include a delivery plan, a detailed delivery plan with timelines?
Yes, it will.
Will that be broken down by area?
Yes, we'll do our best to do that. Absolutely.
Well, I think it's essential that it does include that. Something high level just won't really cut it, I don't think. There's a lot of expectations coming out of the population here in Perth and Kinross, and I'm sure my fellow councillors will attest to the fact that we have significant caseload regarding access to primary care services, primarily GP services, to be fair. And I certainly have been saying there's a strategic plan being developed, and so I think people are waiting to see what that will be. And I also think, you know, David, that I think we absolutely have to think about where and how we deliver services. I think we mentioned earlier on that there's a property review taking place right across Perth and Kinross in terms of public buildings and how we can utilise those better. So if you know that, I would suggest respectfully, if you can, if you have time, to engage with that process, just to see what might become available. You know, there's nice big campuses all over Perth and Kinross and the rural areas in particular. I don't know what capacity they have or how practical it might be, but there's certainly opportunities that I think needs to be explored. Thank you. Thanks, Chair.
I think we'll stop any questions now, and thank you very much for your presentation of the paper. There are a lot of expectations and a lot of excitement maybe about what's going to come in February 24. So, and thank you very much and good luck with it.
Thank you.
Thank you. So we are at 5 o'clock. We have two papers that we definitely need to get through. So that's the next two items. So can I suggest that if anybody needs to excuse themselves, they do so while we're continuing the discussion on the next two papers, if that's all right. Item 6.8 on the agenda, and I'm going to ask people to be very concise, succinct with their questions, and concise and succinct with their answers and comments. I don't want to miss anything out. but I realise that we started a bit late and we are up against the pressure of time here. So item 6.8 on the agenda is the notice by Victoria Practice Glover Street Medical Centre, Perth, to cease their Methven branch surgery contract. I think, Jackie, Chief Officer, you're going to do a brief introduction, and then we'll pass over to Dr. Shaw and Debbie McGill, who's the Primary Care Service Manager.
Thank you very much, Chair. I'll try and be brief and conscious of the time. This report informs the Perth and Kinross Integration Joint Board of the intention of the Victoria practice to cease GMS services from its branch surgery in Methven from the 1st of January 2024, and to provide these services to all of its registered patients from its Glover Street premises in Perth. NHS Tayside Primary Care Services is responsible for the contractual arrangements for the provision of these services and have worked with the practice to consider possible options to support continuation. And the Health and Social Care Partnership has supported the practice to carry out a robust consultation and has completed a comprehensive equality and fairness impact assessment that you have in your papers. And I'd like to acknowledge the work of both teams in terms of the work that they've carried out. And to highlight the impact of the changes on the registered patients and groups with protected characteristics. The key issue that arises reflects some of the conversation and discussion that we've had around the characteristics of providing health and care in Perth and Kinross, and they relate to accessibility and support for transport. So you'll see in the report that the Health and Social Care Partnership continues to explore the potential for community transport options and the cost implications of that. And pleased to hand over to David and Debbie if they've got anything to say by way of introduction.
Sure, I'll try to be brief. Essentially, Victoria Practice has a GMS contract for a little bit over 11,000 patients, most of whom live within Perth, but it does cover an area that stretches about 13 or 14 miles out west of the main surgery, out past Madity. It's had historically a branch surgery based in Methven, which it's operated for many years. It's unfortunately, as with many practices, had resiliency issues. They've had retirements and they've struggled to try and replace retiring partners. There are about 1,400 patients registered to Victoria Practice who live within Methven. And following a realignment of their offering of what had initially been a 20-hour per week surgery to 2 mornings, I think a Monday and a Friday morning, the practice has reviewed the clinical capacity that it has and reviewed the footfall within Methven, and have deemed that they no longer wish to continue with the branch surgery. They feel that they can use the clinical time more efficiently if services are based entirely within Perth. Practice state that they have between 1 and 2 patients per week availing themselves of the surgery in Methven. Obviously does have an impact. I think it takes 2 buses to get from Methven into Perth City. So for those 1 or 2 patients per week, there will be an impact. There may be patients who would have availed themselves of a service face-to-face, obviously, beyond that, if such a service had been available. So the numbers that the practice reports may be an underestimate of the total demand. That said, ultimately, from a contractual perspective, the practice is free to give up its contract, and the consequence of giving up that contract is that they no longer receive funding to support the branch surgery because it will no longer be delivering GMS services. and there isn't really too much that NHS Tayside can do to compel the practice to retain the branch surgery. Now, I'm never keen on surgeries closing. You might not believe it, but it's a true fact that I do everything that I can to try and maintain the network of surgeries that we have across Tayside. And it's my regret that unfortunately in recent years we've lost Bridge of Arn within Perthshire, and we've lost Freecombe, Rye Hill within Dundee and Angus. So, as I said, we have worked very hard to try and maintain, firstly, some form of limited service within Methven. We worked with the practice to try and work out if there was anything that they could deliver. We've worked with the partnership to see if there are partnership services that could be delivered there. I think the partnership have workforce constraints, which mean that that doesn't appear to be an option. So I think where we are just now is we have a contract termination request from the practice. There is no registered population that goes alongside that, so there isn't an option to set up a de novo practice within Methven. There's no contractual mechanism to allow that to occur. So I don't really see much in the way of an option with regard to the contractual matter. But absolutely, I think it's well worth the IJB considering what mitigations may be put in place. So I think this is extremely regrettable. I've worked hard to try and prevent this becoming an actuality. I'd be very keen now to stop and allow questions.
Thanks, Chief Officer and Dr. Shaw, for your introductions. Perhaps I'll just kick off with some questions. I don't follow this argument that in terms of sustainability, surely at the moment there's X number of GPs providing Y hours of care at Glover Street and Z hours at Methven. So you get a total of Y plus Z hours of care, but you're going to close Methven and then move everybody to Glover Street, but you're still going to be providing the same number of hours of care from one location with the same number of GPs, aren't you?
So 2 points. I'm not going to close Methven. The practice is wishing to give up its contract. So the practice wishes to no longer deliver a service that they were previously contracted to deliver. So I just want to be very clear on that. I think secondly, the practice's contention is that a practitioner will travel from Perth to Methven and then travel back again. And there is a significant amount of travel time involved in doing that, which represents, I guess, some reduction in the clinical number of hours that can be spent. And I believe that there are also additional there is additional work in maintaining a branch surgery above and beyond the clinical input.
Okay, thanks. So you mentioned that there would be a reduction in the fee paid to the branch because they were no longer to the surgery because they were no longer providing a branch service.
There would be no further funding.
Right. So I'm just wondering then, in the last paper that we looked at on the plan on the page, and we were talking about working across the system to ensure resource transfer as services change and evolve. And obviously one of the potential mitigations is a community transport initiative. So I'm wondering how much resource is freed up by not continuing with provision of the branch surgery, and whether that is made available to support the community transport mitigation.
Sure. So currently there's, I think, £18,000 a year that the practice receives to support the costs of running the building. That comes from a ring-fenced pot of money that's for GMS premises. Now, there are issues in terms of removing money from that pot. That question has gone to the group that runs that advises on primary care premises and infrastructure. It meets next week. And one of the questions that we have there is, firstly, is it possible to use that money for a purpose other than that for which it is allocated? So I think beyond that, there's a question of, if you cannot use the money for a purpose for which it is allocated, is there any other money that you can use that comes from NHS Tayside? I think there have been concerns expressed as to what form of precedent you set if you do that. We have had a number of branch and surgery closures across Perth, Tayside, Scotland, and if there was transfer to a service that hasn't historically been delivered, which is transport, then it does set precedents for other areas. It also sets precedents for patients who live in Methven who are registered with one of the two other surgeries that cover the area, in terms of, are you only going to provide transport for people who are registered at Victoria, or are you going to provide it for everyone? So it's a complex question. It will be reviewed. I do not wish to, I think, tell you exactly what the outcome is, because I don't know what the outcome is going to be. But that is the process with regard to that specific question.
Okay, thanks very much. I mean, in terms of setting a precedent, I think that actually would be precedent setting, possibly in terms of working across the system to ensure resource transfer as services change and evolve. And I think it would be a welcome precedent to the residents of Perth and Kinross. As you noted, we've already lost Bridgeverne branch surgery, but additionally, Perth and Kinross has lost Bridgeverne GP surgery, but we have also lost the Invergowrie branch, the Bank Foot branch, and the Blair Athol branch in just the last few years as well. So this is a fifth blow to primary care provision in Perth and Kinross. Councillor Frampton, I think you want to come in.
Thank you. I just wanted to say, whilst we can understand the reasons of safety and staff shortages and patient safety being behind the closure of provision of services from the Glover Street GP practice, as one of the ward councillors for the area, it would be remiss of me not to have it noted on record that this closure is disappointing for the patients of Methven and surrounding areas who attended the branch surgery. The cause of concern around public transport and lack of it, and the costly impact patients may incur on having to travel to the Perth Glover Street surgery is seen as very negative and as potential to contribute towards financial insecurity for many who are already struggling in this present cost of living crisis. I've also noted that there is a hope for a community-led transport system going forward to help patients get into the surgery in Perth. But I also note that so far it appears to be there is very little interest for individuals in Methven to take on this responsibility. I hope going forward focus is maintained in finding a solution to the transport issues. It is also extremely disappointing that the decision not to make Methven surgery a wellbeing hub was taken as an approach to retaining services of minor care, such as wound care, warfarin clinics, diabetes clinics, blood pressure monitoring, would have been welcomed, especially with the older population of the area concerned. Unfortunately, the closure of yet another rural GP branch providing primary care is not viewed favourably within the public. And I just wanted to say that.
I don't think I could really argue with any of that. I think this is an extremely regrettable occurrence. I would not ever have wished the branch to close. I can understand the practice's reasons for closing the branch. I can't stop them from doing it. If they give up the contract, they give up the contract. I can also understand why the partnership has chosen not to invest in near patient services within Methven, given the disposition of the workforce. I think all of these things are really very difficult, and I think they do strike out that community. So I entirely agree with what you've said, and I will absolutely take on board all of those points.
Thank you.
Councillor Illingworth.
Okay. Three comments. First of all, this is the third closure that I've been involved with, either as ward councillor or as a member of the IJB, and now both. The communication on this closure has been better than the other ones, from the practice and from the NHS through Debbie McGill and Lisa Milligan. So thank you for that. The second comment is that my dad was a GP, and when he retired about 30 years ago, there were 100 applications to join his practice, and those days are long gone. My dad was on call 3 nights a week, and GPs don't want that anymore. And they're retiring, they're voting with their feet, and they're retiring early, and they're aiming for part-time contracts. I think those are the driving forces behind the closures. And the third issue is, or third comment is around setting up a community-based transports in Medfin. I've asked a lot of the main players in Medfin community if they want to get involved, and I thought I'm just going to wait until after Christmas, and we'll just see if we can generate a bit more interest in setting up, because it's all down to having a leader, a community leader who's involved, who's prepared to lead such a thing. Once that's in place, then the rest of it follows from that. So those are my 3 comments. Thank you.
Thank you, Dr. Peterson.
Mine was just a general comment, and obviously I've got a vested interest as a GP. I've been involved as part of this IJB in lots of discussions around the closures of GP, and I sometimes find the discussions very difficult to hear. And I think we need to consider a move to how we think about these things. There is no one in this room or on that screen who want this practice to close. There is no one in Victoria practice that want this to move, but want this to close if they had any other option. We have had indications from Zoe over there about how important patients want our GP surgeries, and yet when we have these discussions, it feels sometimes as though it is attack. For me, this needs to be a consideration of us recognising that these are practices, and this is a vital service in our NHS that is falling round our feet. And instead of us attacking each other or talking about this, we need to be thinking how we can collaboratively approach this. And I think that's really important, because this is, the GP services are fundamental to everything. We've heard it continually through this, but yet we are having these discussions which feel confrontational. David doesn't want this to shut. Hamish doesn't, no one does, but we need to move that rhetoric from it being a challenge and, well, what are you doing, to us actually all working collaboratively together to save what is fundamentally a really important of our NHS system. And if GP surgeries go, the whole of the NHS goes.
Martin.
Just some practicality, if it does close, who owns the building?
The practice owns the building.
And was there any money that was given to them to invest in that building that can be reclaimed?
No. There's regulations as to how buildings are funded. I could bore you with this if you really want, but the short answer is no, and I can give you a longer answer if you want.
Anyone else? Jackie, Chief Officer, and Councillor McCall.
Yeah, I think just to pick up on
Dr. Peterson's comments about how we're going to tackle this in the longer term in terms of our long-term approach here. This is a symptom of a much bigger problem, and we've heard our update in relation to the strategic needs assessment. We've heard the update in terms of Director of Public Health's report. We're developing a strategic commissioning plan. What's going to come through, I think, from the GP premises surgery is around accessibility and transport, and I think it's going to be a key issue for us. And as an IGB, we're not going to be able to solve that on our own. I think that collaborative approach is going to be required, which takes us back to what you were saying, Councillor McCall, about all partners will have to engage on this really difficult issue that we have for the locale and the geography and the demographics that we're here to serve, because that's our prime purpose. So thank you.
You did, but I always want to come in again and just quickly say that while I fully appreciate what Dr. said, it was the BMA created the contract, and it seems the pressure has been put on the people that are actually trying to help the constituents and the people in their area. So if the negotiation has to happen, it has to be between the BMA who created this contract, because we didn't have this problem before the new contract.
Can I come in on that? Will that be all right?
I think that's probably a wee bit outside the scope of our discussion, if that's okay, Dr. Shaw. So I'll bring in Councillor McCall. Thank you.
Okay.
It's just really quickly, and I think Jackie captured most of what I probably wanted to say. It's not meant to be confrontational against any individuals, and I think a part of our role, I think, sitting in this IGB is to challenge. And so I will try and be less confrontational if I'm challenging in that way. But this has been a crisis that's been coming long before I sat in this IGB. And so therefore, I think, if we do ask robust questioning, it's mainly to try and generate some sense of urgency. And nobody's more in the front line than GPs, but not far behind you, I think, must be elected members, because we get all sorts of feedback and access for the public. And so, I understand where you're coming from, but it's an urgent matter. And I think this primary care strategy is crucial to delivering all of this. Thank you.
Absolutely. I think as an elected member, you're there to put forward the views and needs of the population that you serve. And if you weren't asking robust questions, then I would be not wanting to vote for you. I can't vote for you because I live in Fife, but I think on a point of principle, the elected members are on an IGB for a purpose, and I think you're doing fine. Crack on. Probably don't need to be patronised by me at 5:30 on a Wednesday, but that's really all I want to say.
Thanks. So I'll run through the recommendations in the report for no other comments or questions. So that we acknowledge that the Victoria practice has given notice to close their branch surgery in Medvin and to provide GMS services for the registered patients from Perth. To note the work carried out by NHS Tayside Primary Care Services to consider possible options to support continuation of general medical services in the branch surgery, and the outcome that this application cannot be declined. Note the outcome of the consultation carried out by the Victoria practice, supported by the Health and Social Care Partnership, and the outcomes of the Equality and Fairness Impact Assessment, and approve the mitigation proposed by the Health and Social Care Partnership to seek to support or fund a community transport solution to assist patients travelling from Medvin to Perth for GP appointments, and presumably in the reverse direction as well. I'm going to add another recommendation on, if that's okay with the board. After the Invergowrie discussion, we requested a lessons learnt meeting at that point. It was not known to the board at that point that Medvin had already submitted their notice to close. But we did have a meeting, we did have a lessons learned session, but we didn't document any outcomes from that session. And it was actually presented more as a looking forward session rather than a learning lessons session. But I think there are lessons to be learned in terms of how we deal with these, how we engage on these issues. As I indicated, this is the 5th surgery or branch closure facing Perth and Kinross residents. Councillor Illingworth mentioned earlier the fact that we are supporting the 2C practices in Dundee and Angus, but at a financial cost to provision of services in Perth and Kinross. And I certainly was in the chair for the meeting of the IJB back in 2019, where we considered the Bridge of Erne closure, and at that point the direction of the board was to we should staff should seek to bring forward a plan to restore restore services to Bridge of Erne as soon as possible. Obviously, this is us 4 years later, so I think there are genuine issues of consultation and engagement and partnership working, just as Dr. Peterson you said, that we need to engage on. But I think there were also lessons that we have the opportunity to learn but are not doing in terms of protecting the sustainability of these services going forward, which are so vital to the residents of Perth and Kinross that we're here to represent. So that's an additional recommendation, just to hold a follow-up lessons learned session on the process, if that's okay with you, Dr. Shaw.
Absolutely. I think it's very important to learn from adverse events to work out how you could try and avoid that thing in the future. I couldn't guarantee that you wouldn't get another closure at some point. General practice is currently extremely fragile. I've got a surgery that's up for closure in Dundee in about 4 months' time, and I have no doubts that over the course of the next couple of years we'll have other practices in extreme difficulty. So we should learn from all of these to work out how best to approach this, so that we aren't in the situation where we've got a meeting like this. Very much want to take part in that.
Thanks very much, Dr. Shaw. I think yeah, your point is well made. We do need to make sure that we can support the sustainability of services. Bernie, you want to come in, and then I'll come to
Sorry, I actually, my comment is probably a little bit too late now, but it was really only to say when you're referring to negative comments, and I think as a public partner, carer rep, and you know, the comments that we brought yesterday to the strategic planning group meeting, and that Zoe shared, it is, you know, we are speaking for people out there, and it's not that we don't understand, but I would link to the fact that we've sat here today and we're looking at a primary care plan, and it talks about, one of the columns is, you know, bringing things closer to the people where they want it, in the right place, and it just seems that it's the complete opposite when we're talking about losing crucial GP practices. Thanks very much.
Sure. Very quickly, if I come back on that, the fact that we've got that in the strategy, I think, is ammunition for trying to prevent further diminution of services. So if you don't have something in the strategy that is about supporting premises and services close to where patients live, then you're setting yourself up for more closures. So very much in favour of trying to keep the existing footprint that we have. The strategy should echo that ambition. That's the reason why it's in there. I would be dishonest if I didn't say that sometimes it goes the other way. But we need to say what our values are, and our values are keeping local services close to communities. And sometimes we don't deliver on that for reasons that I think have played out today.
Thank you, and Ms. Hampton.
I think we need to be very clear. I'm happy that you have added another recommendation on about lessons learned, but I think we also need to acknowledge in that discussion that a lot of the primary care work that's been done gives us an overview, and I think it's important to remember. And I think I got you right, David, when you were saying there was an average about how many patients a week were visiting this sub-office?
The
One or
practice
two?
reported that they were getting 1 or 2 patients a week. I think the rest were dealt with remotely.
So we're getting 1 or 2 patients who are attending this branch office that we're getting upset about the closure, and I understand why, but I think we need to be realistic when we're looking at the crisis in primary care. The resources being focused for 1 or 2 people a week for a GP to go and sit in a half-empty office. Sheila, you may, but people need to take some responsibility. We're talking here also about trying to get community transport where people are not interested in creating their community transport. So what we're talking about is people moaning about GP practices closing, about not having the resources and everything being brought to them, but not interested in engaging in any part of the solution. So all I'm saying is in the lessons learned, we need to look at the responsibility of people and communities and how our NHS is working. And I think, I'm sorry, but I think I need to voice that, because I, quite frankly, am getting not distressed, but fed up of hearing about this complaint about primary care not delivering where it should be delivered, and communities have a part to play in that as well. Thank you.
Okay, if there's no further comments or... Oh.
Can I come back with a comment, Colin? I'm really sorry, but just on that last point, and I think there was a crucial statement there. It was about saying 1 or 2 patients that attended the practice, but I think you actually said that the others were remotely. So maybe they were given the opportunity to say, well, actually, is a telephone call appropriate so we don't have to go to the practice? So, you know, it's maybe not 1 or 2, it could have been a lot more, but they took the option to have a remote consultation. Thanks.
I just need to address that, Beth. You know, I understand if it was only 1 or 2 patients and I have to rely to some extent on the ward counsellors and feedback. But I also know that a large part of the casework that I get is because people cannot get face-to-face appointments with their GPs because they're being advised, this is how we can speak to you. So I think that's everywhere. It's in Perth City as well, in the rural wards as well. And as more and more of the responsibility for delivering GP services is migrating back into Perth City, it's becoming a bigger issue for all of the patients who are registered with all of these practices. But it's probably one of the single biggest things that people feel that they cannot see their GP on a face-to-face basis. So it may well have been a practical reason why people were being seen remotely, but it may not have been driven by the patients themselves. That's all I'm saying. I don't know, but it may not have been.
Thank you. Okay, can we draw this to a close now then? So can we agree the recommendations with my additional recommendation for a further lessons learned session? Thanks. That was met with overwhelming excitement. Okay. Great, thanks. The Vice Chair's excited. So item 7 on the agenda is governance, and 7.1. Sorry. Oh, sorry. Did you have your hand up for a final comment there, Dr. Shaw?
I think he was just waving goodbye. He was just waving
right. Okay.
Goodbye.
Okay.
Thanks,
Sorry.
everyone.
Yes. Okay. Thank you to the members who were attending online for that item. The other item that we absolutely need to discuss today and just approve is 7.1, appointment of the Chief Finance Officer for Perth and Kinross Integration Joint Board. Chief Officer.
Thank you very much, Chair. I'm aware of conscious of the time, but it is important that we discuss this and consider the recommendation, which is to approve the commencement of the recruitment and appointment to the Chief Finance Officer, stroke Head of Governance and Performance post, and a permanent appointment to that. You'll know that the role has been filled on an interim basis since January 2023. That's almost a year. And if I see that Donna has left, but really extend my appreciation to Donna for steering us through last year's budget or this year's budget setting process and the challenges of the year. You'll note that there's a revised role profile which covers the statutory requirements of the CFO, and that's the Chief Finance Officer role for the IJB. That's been devised and includes a portfolio of responsibilities that covers risk, governance and performance. The recruitment process is outlined in the appendix to the report, and that's what you're being asked to approve, recognising the technical and professional expertise that's required in the constitution of that panel, the appointment panel. And also a proposal to include representation of the IJB, the IJB's Audit and Performance Committee and the Strategic Planning Group. And it's not in the paper, but I have already approached Serene McCartney as co-chair of the Strategic Planning Group of the IJB to join the panel. Happy to take any questions, and we'll also if time allows, engage in further discussion following this meeting about the wider scope of the senior leadership arrangements with IJB members. Thank you.
Okay, got any questions or comments? Councillor Illingworth?
Yeah, it looks like a pretty reasonable process, so thank you.
I'm going to assume that nobody doesn't think we should, or nobody thinks that we shouldn't start the commencement of the recruitment and appointment process for Chief Finance Officer. So if that is the recommendation, can we agree the recommendation? Thank you very much. Okay, we're now at 5:36. I think if you give me another 4 minutes, we can get through the remainder of the items pretty quickly. So item 8.1 on the agenda was the audited accounts. The introduction or the comment that the interim Chief Finance Officer was going to make was simply that the accounts were approved at Audit and Performance Committee in October. The audit opinion on the accounts was unmodified. The opinion is given when the auditor concludes that the financial statements are presented fairly in all material respects and in accordance with financial reporting framework. And the auditor found that the IJB has appropriate and effective financial management arrangements in place, and that governance arrangements are appropriate and support effective scrutiny, challenge and informed decision making. There was one recommendation that the IJB should ensure it completes its self-assessment against the best value characteristics and report this to Audit and Performance Committee, and this has been agreed and planned. It's planned to bring this assessment to Audit and Performance Committee in March 2024. That said, therefore, can we note the audited accounts? Agreed. We discussed the winter resilience plan at our special meeting in October and said that we would provide the NHS Tayside wide winter resilience plan, so that's there for noting as well. The work plan is provided. At the moment, there's a heavy preponderance of items on the agenda for February and a single item agenda for March, which is the budget. If it's acceptable to the board, the support staff would work to achieve a more equal distribution of items between the February and March meetings. So we would not be solely considering the budget in March. Agreed. And then the last thing is the future meeting dates for 23-24. We have two. We have a date in February and a date in March. March will be the budget plus other things. February, it's proposed that we look to take the IJB out so that we can see other areas of Perth and Kinross rather than inside of the council chamber. So if it's all right with the IJB, officers will look to hold that meeting in Loch Leven campus in Kinross, when we can also maybe take the opportunity to visit the health centre. It's hoped that that would make the that will help bring the Health and Social Care Partnership Board a bit closer to some of the facilities, a bit closer to people in some of the more rural locations, and a bit closer to some of the staff who otherwise might not come into contact with, if that's agreeable to the board. And then we will subsequently as well produce shortly a schedule of meetings for the remainder of the year. And then simply we had the IGB development session dates for noting. I was going to raise another issue, but about the visibility of the board, but I'll email members separately about that. Thanks very much for everybody's attendance, those online and those in the room. Thanks for bearing with us for a long agenda, but it was important to get through all of those items, I think, and acknowledging as well that we did have a delayed start by 35 minutes, so we are only finishing roughly on time. But thank you again to all officers for their attendance and for answering questions, and for members of the board for their attendance and for asking the questions. That's the meeting adjourned.